you in the
That's
hospital?
my office. My office.
Office. Yeah, but it's good that you have a very comfortable costume.
I did my case and
Yeah.
I'm ready for the webinar.
Webinar, yeah. Thank you very much. So actually, this is my first time to host this webinar. I'm so glad my friends and has joined us this meeting. Actually, this webinar was supported by Mini Invasive Surgery Journal. So, as you know, Mini Invasive Surgery is the new journal, but it is becoming becoming a good impact now. So I appreciate the Mini Invasive Surgery as well. And Lilian is from Journal Mini Invasive Surgery, and he will speak up. She will speak about the journal after our session. So I think now the time is 9. So oh yes, the Lilian. You see. So time is 9 in Korea. I think it's time to start. So thank you very much, friends and colleagues. It's a great honor for me to have a session of this. So I appreciate all the friends and also Journal Mini Invasive Surgery and Lilian for making this excellent webinar. The topic of this webinar is a new era of minimal invasive HPB surgery. I think this speaker is the most famous and most renowned surgeon in the world. So they are friends, but I respect them much. So there are 1, 2, 3, 4, 5, 6. Actually, 6 speakers, and if we include Lilian, there are 7 speakers. So first speaker is my friend, Dr. Roberto Ivan Troisi. So he will speak about the minimal invasive liver surgery and in post-superior segment. I think we can give more time if I finish American speech. So I'd like to ask one by one to say hello to everybody. I think in the screen, I see Dr. Aslam Ejaz. Would you say some speech to everybody?
Hi, my name is Aslam Ejaz. I'm a surgical oncologist, HPB surgeon at The Ohio State University. Thank you very much for the invitation and the honor to present today. Appreciate it.
Thank you, Dr. Ejaz. Dr. Troisi.
Hello, everybody. My name is Roberto Ivan Troisi. I'm chairing the Department of HPB and Transplant Surgery at Federico II University in Naples. I'm very glad to be here for this webinar with distinguished speakers.
Thank you very much. Thank you, Dr. Troisi. Dr. Joe. Dr. Joe is my colleague. Dr. Joe.
Yes. Yeah, everybody, I'm very good to see you. I'm Dr. Joe. I'm working with Professor Han in Seoul National University Bundang Hospital. Also, I have learned laparoscopic liver surgery from Professor Han, and today I'm very happy to present our outcomes. Thank you so much. Good to see you.
Thank you, Dr. Joe. And we move to Dr. John Martini. Dr. Martini, please.
Yes, good morning and good evening, everyone. Thanks for the invitation, Professor Han. It's good to see you. And I'm a HPB surgeon in Charlotte at Atrium Health.
Thank you, Dr. Martini. And Dr. Panaro.
Yes, thank you. Thank you for the invitation. I'm Panaro. I'm a professor of surgery and HPB surgeon in Montpellier, France.
Thank you, Dr. Panaro. Dr. Kaufman, please.
Hello, everybody. Nice to see you. I'm here for Professor Ugo Boggi. I'm an HPB and transplant surgeon in Pisa, at the University of Pisa. Thanks.
Thanks, Dr. Kaufman. The first speaker is, as I already introduced, my friend, Dr. Roberto Troisi. Dr. Troisi, would you start?
Yeah, I have to share my screen. I guess I can do it because I have no pre-registered video. Do you see my screen?
Yes.
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 Okay, I hope I will be able to see all the slides. Just a moment. Do you see the second one?
Yes.
Perfect. Okay. Thank you so much again for the invitation. This is a slide stolen to Professor Han some times ago. Just to tell you that we can do by minimal invasive approach many type of liver resections, even segmentectomy or subsegmentectomy, according to the Takasaki technique. And here on the right side, you see listed all the, let's say, most difficult type of resections with the latest improvements like total explant hepatectomy, laparoscopic robotic implant, which is, of course, still experimental, but just to tell you that the story is going on and the novelties are unstoppable. The other slides is just depicting all the technical adoptions for posterior superior segments. You can see all the tips that we are using, especially for the laparoscopic approach. I think most important are the placement of intercostal trocars. Of course, it depends from the anatomy of the patient. It's also very important to exchange the instruments into different trocars, so working with both ends and maybe also using simultaneously two devices, so the so-called dual handling. And this is an example of instruments exchanges through the trocars to facilitate the resection angles, to have the best direction. And you have also to move your feet like an organist or a pianist, because it's very important so to master the energy instruments. This is a slide which is depicting the evolution of my activity now in Naples. You can see in the 2.5 year time, the minimal invasive approach are improving. Actually, 84% of HPB surgery is done by minimal invasive approach. You can see also the improvement of let's say, the input that the robotic approach gave us, especially for pancreatic surgery. And you see here the difficulties for approach of posterior superior segments. So we have curvilinear resecting surfaces. We have a limited working space. We have also limited exposure of deepest liver parenchyma close to diaphragm. Ultrasound evaluation is difficult, especially in cirrhotic patients. And sometimes we have a difficult control of hemorrhage from tributaries of the major hepatic veins. This is a study of a few years ago, multicentric European experience showing the advantage of laparoscopic approach to posterior superior segment with respect to open surgery. This is a propensity score match analysis. You can see that by doing the laparoscopic approach, we can decrease the overall complications, and even the pain is less, as well as the length of hospital stay in these well selected patients. The oncological results are absolutely sound for HCC, but also for colorectal mets. And other worldwide experience are also showing that with this approach we can have, we can reach almost the textbook outcomes in improving the quality of surgery for lesions in posterior superior segments. These slides show the actual trend of laparoscopic, but also robotic liver surgery. And you can see that the indications between open, but lap and robotic approach are similar. So the first indication are malignancies, and on the top position we have HCC, colorectal mets, and there is also an exponential growth of living donor hepatectomy by the robotic approach. The proficiency is measured, of course, for lesions in difficult segments, but also in major hepatectomies. This is very nice work from the Gaia group, showing that we can achieve the mastery in major hepatectomy after 75 procedures. This is a similar experience from the Hans group, speaking about 73 cases. And this is the situation about robotic surgery, a type A experience, showing that with robotic approach, we can shorten the time, the learning curve, and so the mastery of major hepatectomies. We have more and more data, available data and evidence that by the robotic approach, we can have similar, maybe also improved results for posterior superior sectionectomies, for instance, as depicted in this study from multicentric worldwide study led by the group of Singapore. So we can have less bleeding, less intraoperative transfusions with the robotic approach, which is important, especially in oncological patients. And one of the latest paper is also showing and confirming this, even including a lower rate of conversion to open surgery. Of course, there is a bias in this study that some of advanced laparoscopic surgeons are met the robot to explore the potential of robotic surgery. But anyhow, we can certainly say that the robotic approach is not inferior and maybe can help in some difficult situation. I will show slowly a video of a robotic segment 7 resection in cirrhotic patients, so a 60-year-old male with this diagnosis of 2 lesions in segment 7. This is the position I adopting for this approach. You see here the CT scan with the 2 lesions. And I will accelerate. So this is the intraoperative view with tumor enhancement, 2 tumors in segment 7. And in this case, I will have this Grisonian approach for segment 7, robotic segment 7. So this is the first step, the classical cholecystectomy. I think I can skip this phase. It's very interesting, of course, you know very well, the Type Pro screens, which allow us to look to the ultrasound, to the CT, and even to the rendering. We are doing rendering, CT rendering simulation with Japanese software, the Fuji software, for difficult cases. This is also very important in university hospital for teaching purposes. This is the approach of the Rouvier sulcus with attempt to do a Glisonian approach at that level. So you see how is, let's say, is respect to the laparoscopic approach, the manipulation of the instruments along these blood vessels, which is, let's say, a must for this kind of approach, parenchyma preserving approach. I will skip and go ahead. The use of Pringle maneuver is I think, important, especially in robotic surgery. This is an internal Pringle maneuver, which works very well and maybe facilitate also the Glisonian approach, showing dry field. So you can see the different steps of isolating the portal vessels, putting ligatures like in open surgery, and then resecting in a very anatomic fashion the parenchyma. I skip. So I think now is the moment of the green. Yes, this is the counter staining. So you see here segment 7, which was firstly isolated by the Glisonian approach. So we are drawing as usual the landmarks of segment 7, and just before the resection starts in this case with we check again with ultrasound, of course, to be sure that our segments or the tumors are included in the discolored segments. And our approach changed the last times. So we are not using always this harmonic robot, but you will see that the assistant on the table will use the CUSA, so the ultrasound dissector, and these to let's say to improve and do some kind of teaching. So the consult surgeon is now assisting the surgeon on the table. This is contrary to the principle of robotic surgery. So you see here the CUSA. And the surgeon at the console is guiding the fellow of the surgeon on the site on the table. Again, checking with ultrasound, which is very, very easy during the resection. And so we move ahead. Some staplers on the vessels. In this case, there was another branch of segment 7, a little bit deep, and this is quite common. So we are not always in state of isolating by the Glisonian approach all the branches for segment 7. This is an anatomical particularity of this segment. But anyhow, we can do in an anatomical fashion this kind of surgery, the resection of these segments. So it's in this case a mixed transaction with robotic harmonic and the CUSA. And the last phases of the operation are here. I think this is the third stapler, like a linear stapler. And because it's time-consuming operation, the use of harmonic will also accelerate a little bit the surgery. When needed, we can put, as in open surgery, some stitches to have a full control of the hemostasis. So these are the final phases. As in laparoscopic surgery, I'm using you see here the gold finger as a hanging maneuver, and the hanging maneuver, you know very well, can help in doing hemostasis and in attracting towards the surgeon the segments. So this is postoperative course. Discharged after 7 days. You see total pring maneuver, blood loss, which is not little, but it's a cirrhosis. And the operation time was around 400 minutes. So I conclude that the minimal invasive surgery of the liver is a continuous growth, especially for difficult segments. There is actually a trend, increased trend for robotic approach, and I think the introduction of the new platform will facilitate this while diminishing the cost, because I did not speak about the costs, which are very high. It depends also from the region, but usually is very high. The techniques are established for both approaches. And the initial data from the literature are showing that robotic surgery is safe and has similar oncological results of lab. There is one potential is that the robotic is a digital platform, so we can adopt different software and navigation software in the near future. We have shorter learning curve, and we can also facilitate the proctorship. And this is my last slide. Thank you so much. And I give now an endorsement for the next ILS, International Laparoscopic Liver Society meeting in Rome, September 2023. Thank you so much.
Dr. Roberto, thank you very much for your excellent lecture. So actually we have a discussion part, but I'd like to accept one question from any side. Is there any question, or if you have a question, you can raise your hand. If not, I will ask Dr. Roberto Troisi. So yeah, you have both experience of laparoscopy and robot. So I think you are just a few of the surgeons who do lap and robot surgery as well. So about your experience, what is convenient for you for posterior superior segment, laparoscopy or robot? Which is better for you, convenient for you?
I think, so as I told you, being a university surgeon, I have to teach the fellows and the trainees, and the robotic platform is helping me in doing this. If I ask my trainees, how do you see the future of minimal invasive surgery today? They will say, Prof, we see only robots. So there is of course an improvement, a technological improvement. You see it, all the navigation system will be able and will fit all the robotic machines. Why I will choose, especially for PS segments, robots, also because the ergonomy is much more. Maybe I'm getting older, but operating seated is a big advance. You can also drink a cup of coffee, you know, but you have to stay concentrated, focus on your operation, of course. And yeah, I will say we are preferring for the liver. We are preferring now robot for difficult cases, but I think with laparoscopy, you can manage very well more than the health of the liver pathology. The different story is the pancreas. I mean, I never approached the pancreas head resection laparoscopically, but now I'm doing DCP laparoscopic robotically. So the advantage is very clear, and I think the other speaker will tell something about this. For the pancreatic tail, Kimura operations, spleen preserving, and so on, I think with laparoscopy you can do in the same efficient way. But for Whipple operation, robot is really a must.
Thank you very much. So as you mentioned that the robotic is getting more popularity now. So I think as shown in your graph, the case number of robotic will increase more and more compared to laparoscopy. Thank you very much. And also congratulations for the ILLS World Congress, which you are the co-chair of the ILLS. Congratulations.
Thank you. Thank you.
You know, I will host 2025 ILLS as well.
Sure.
I will invite everybody. So thank you very much. And Dr. Joe,
Yes.
would you start your speech? Dr. Joe will speak about the efforts to overcome difficulty of laparoscopic machine learning algorithm to guide.
No.
Machine learning.
No. There is some error in title of presentation. I will show my clips.
Okay. You start. So I think machine learning is very fantastic.
Yeah, but I have no experience about it.
Yeah. So start your lecture, first Joe. Dr. Joe.
Okay, I will do. Thank you. Sorry. Can you see my videos?
No.
no,
Still, I
no.
cannot see. Yeah.
Yeah. Maybe. Okay. I'm sorry. This is first time in this computer, so there is a problem. Okay.
Okay. You can
Yes.
see your video.
Okay, so I'm sorry. This is my first use in my computer. Sorry. My title of presentation is Effort to Overcome Difficulty of Laparoscopic Liver Resection in Unfavorable Locations. I have no experience in the machine learning. So I will start my presentation. This is my favorite title of presentation. Maybe I presented this title of presentation more than 50 times because Professor Han and I have struggled to overcome these problems for more than last 10 years. So I will show some effort to overcome these difficulties. For laparoscopic liver resection in posterior, especially in posterior superior segments, there is still some limitations. For example, for centrally located tumor, maybe tumors are very close to the hilum or major hepatic veins. We call this as centrally located tumor. This is also very big problem when we do laparoscopic liver resection. Of course, open surgery is also difficult because when we do these tumors, some major hepatectomy is needed. So another unfavorable location is this one. Posterior superior segment is also regarded as unfavorable locations. We must think about why this area is unfavorable, because there is some limitations. Firstly, major liver dissection is also sometimes required, and there is some problem in limited visualization, and also when bleeding occurs, it is very difficult to control, and still laparoscopic surgery and some problem in access, and also sometimes it is very difficult to achieve optimal resection margin, especially tumor is located in segment 7. So recently, we have we gave many efforts to overcome this problem, and also when we do major liver resections recently, our short-term outcome have been improved. So Professor Han and publishes almost all kinds of anatomical liver resections, from segment 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Maybe we can do almost all kinds of anatomical liver resections. Also right anterior sectionectomy, right posterior donor right hepatectomy, or we can do almost all kind of anatomical liver resection can be possible by laparoscope. So when we do some anatomical liver resections, we can overcome some limitations of unfavorable locations. So especially when we do anatomical liver resection, most of the limitation can be overcome. However, still we have problems in access and also problem in resection margin. To overcome these limitations, we need some more technical tips. For this kind of small superficially located tumor, it is no problem. It is very easily removed by laparoscope and very easily to achieve resection margins by tumorectomy or anatomical liver resection anyway. However, laparoscopic surgery has some limitations compared to open surgery. For when we do open surgery, the liver resection can be done 4-directionally. However, when we do laparoscopic liver dissections, usually our liver dissection can be done anteriorly or sometimes laterally. However, it is impossible to the posteriorly. So this is a big limitation of laparoscopic liver resection. So to overcome this limitation of access, so we need some additional trocars. So when we apply intercostal trocars, of course the access can be improved. So after we introducing Pringle maneuver, especially when you do non-anatomical liver dissections, and sometimes we apply intercostal trocars. On the position is also very important. So sometimes we do laterally positions. The caudal approach concept is also very important to overcome these limitations. And then after we applying these techniques, also of course the short-term outcome have dramatically improved. So still another problem is resection margins. So for this tumor, smolectomy is easy, no problem. However, this kind of very small, invisible tumor, it is very difficult to achieve sufficient resection margin when you do non-anatomical liver resections. So Professor Han and we recommended for this kind of tumor anatomical resections such as right posterior sectionectomy. However, right posterior sectionectomy is very, very difficult, and sometimes we tried to anatomical right posterior sectionectomy, but sometimes our resection plane go like this, and the surgical margin is not so good. So recently we introduced new techniques like so you can see when we compare the right posterior sectionectomy, so compared to open surgery, there is although no statistical difference. However, you can see laparoscopic surgery has some shorter resection margin compared to open surgery. So recently we introduced some another techniques. So for this tumor, we do like this. Resection start from the root of hepatic vein and then go to like this. And then if the right hepatic vein will be completely exposed, we can guarantee the resection margin. So this kind of operation is called as hepatic vein first approach, and you can see after resection in this area, you can see right inferior vena cava and right hepatic vein is widely exposed. This is very similar to anatomical liver resection. This is definitely not anatomical liver resection, but outcome is very similar to anatomical liver resections. So if we do hepatic vein approach, it can guarantee the resection margins. So there are many advantages of vein-guided hepatectomies, including it is very good to preserve veins, especially when you do donor hepatectomies. Also, it can facilitate anatomical liver resections. Also, it can guarantee sufficient resection margins. So I will show some short video clips about this one. So tumor is very close to the inferior vena cava, located in segment 7, and the most important thing is wide right liver mobilization is very important. After wide right liver mobilization, liver can be lifted to the left side, and then the tumor and the root of hepatic vein can be widely exposed. So I think that especially for posterior segmental liver dissections, mobilization is very important, I think. So yes, like liver lifted to the left side, and you can see the root of right hepatic vein is exposed. So operation start from the root of hepatic vein. So I am following the right hepatic vein like this. So small hepatic branch can be ligated like this. So this is a very same direction of the branches. So usually no injury to the small branches. So for emergency, I isolated the right hepatic vein. So there is a big bleeding. I will clamp the right hepatic vein. So this is not anatomical resection. So I demarcated the resection margins. Also, when you do laparoscopic liver resection in unfavorable locations, mobilization, and then the suture is also very important. So this is pop from the tumor, and this is non-anatomical liver excisions. And we are, yes, so this from the roots, the tumor can be widely exposed. So this looks to be some dangerous, but the direction of branch is very similar to the hepatic vein, so usually no damage. So you can see the IVC and right hepatic veins are widely exposed. So definitely, of course, definitely it can guarantee the resection margins. Post-OPCT shows no problem. So recently, also many reports showed that anatomical liver resection is better than non-anatomical resection, and sometimes the non-anatomical resection is better than anatomical resections. Still controversies, but in posterior superior segment, if the patient is well selected and then non-anatomical liver resection is well done, our outcome shows that laparoscopic non-anatomical liver resection is almost similar to anatomical liver resections in posterior superior segment of the liver. So, ladies and gentlemen, this is my summary and conclusions. Laparoscopic liver resection in unfavorable location has some limitations, but most limitations can be overcome by major hepatectomy or anatomical liver resections. For invisible small tumors, if we do vein-guided hepatectomy, it is very good. And also non-anatomical liver resection is also can be a good option to treat this tumor located in unfavorable location. Thank you for your kind attention.
Thank you very much, Dr. Joe, for your excellent presentation, excellent lecture. So I try to invite any question. Oh, Professor Troisi, please.
Hi, congrats for the nice lecture, Jae-Young.
Thank you.
Just a question. Usually the segments, the segmental territory is delineated by the portal branches. Now,
yes.
by combining this with the ultrasound, you can have, of course, a guidance of your anatomical segmentectomy, and also you can check the position of the tumor and the cutting edge, the margins, okay? Now,
yes.
I didn't see the use of ultrasound. Do you think that this hepatic vein first approach will eliminate the need of intraoperative ultrasound? And in which way the hepatic vein first approach will really define anatomically your segment, because you don't look first to the portal branches, but you see first the enemy, as I say. The hepatic veins are the enemy of liver surgeon. So you go first cranial and then you go down.
Yeah, of course, ultrasound is still very important for laparoscopic liver resections. Without ultrasound, maybe I cannot do, especially anatomical liver resection, maybe I can do without ultrasound, especially for donor hepatectomy, we can do without ultrasound because we know the anatomy. However, for non-anatomical liver resections, demarcation, post demarcation, ultrasound is very, very important. Maybe for my videos, I skipped the ultrasound, but maybe I applied more than 10 times during operations, especially to achieve resection margins. For vein guide approach can guarantee deep margins. For lateral margins, of course, ultrasound demarcation is needed. Of course, ultrasound is very important. So this kind of operation, the result is very similar to anatomical liver resection, but the concept is slightly different. The just result is very the inferior vena cava and the right part vein will be widely exposed, maybe almost very similar to the anatomical liver resection, but maybe anyway, for definition, my operation is non-anatomical resection anyway.
I don't want to stress anatomical versus maybe anatomical. I'm not Maguchi, but I try to see if there is an additional interest to do this way, which is nice. Did you see that with the hepatic vein approach, you can also limit the blood loss during your operation in the posterior superior segments? Do you see other advantages besides not narrow in margin, tumor margin?
Okay, thank you. It's a very important question. For my video show that the normal liver looks to be almost normal liver. So at that time, when we do hepatic vein approach, usually almost no blood loss. However, in cirrhotic liver, when we start from the root of the vein, maybe some massive bleeding can be occurred. So at that time, the Pringle maneuver is needed. However, when we do segment 7 resections, Pringle maneuver sometimes not so efficient because the backflow from the inferior vena cava is very, very high. So cirrhotic tumor, maybe this kind of approach cannot reduce the blood loss, I think, in terms of blood loss.
Thank you.
Thank you very much, Dr. Joe.
Thank you.
So we will move to the next speaker. So we will discuss in the last part of this session, in the discussion time. The third speaker is Dr. Fabrizio Penaro. He's from French, and Dr. Penaro will speak about mini-invasive surgery and the liver venous deprivation for colorectal rectal liver metastasis. Dr. Penaro, please.
Yes, thank you very much, Professor Han, Gianluca, and I would like also to thank my best friend, Roberto Troisi from Naples. He's one of the best surgeons in the world. So yes, I'm sure. I visit Naples and I saw many operations in robotic surgery. It's a very good surgeon. So I try to share my. Could you see my slide? Could you see my slide?
Yes, I can see.
Yes, we can see.
Yes, hello. I would like to present our experience about liver venous deprivation. Do you know we are the pioneer in Europe, and especially with the mini-invasive surgery. So this is the plan of my presentation. Do you know very well, I think, the result of the portal vein embolization to optimize the future remnant liver? We have 20% of failure, 15% related to tumor progression, and 5% related to insufficient future remnant liver volume. What to do after PVA failure? Today we can do the embolization of the segment 4. We can do also ALPS, and in our centers we propose the liver venous deprivation. As you know, the hepatic vein embolization was proposed in 2009 by Professor Wang. He performed the hepatic vein embolization 2 weeks after the portal vein embolization with good result. And in our center in Montpellier in 2016, more than 5 years ago, our radiologist, Professor Gouillou, decided to perform the hepatic vein embolization and the PVE simultaneously with very good result. This is the physiopathology of the liver venous deprivation. Is the hypothesis proposed by Professor Ko. We have in a hyper arterialization of the sinusoidal space. So there are 4 steps in this technique. The first is the puncture of the right hepatic vein. We adopted in Montpellier the transhepatic approach. We have the second step, the portal vein embolization, glue and occlusion with a mixture between glue and lipidol. The third step is the occlusion of the hepatic vein with the alpha placer vascular plug, 75% oversizing. And finally, this is the last step, but I think the key point of this technique is the venous collateral occlusion after hepatic vein embolization. As you know very well, in this paper, you can see that in Budd-Chiari syndrome or in case of tumor occlusion of the hepatic vein, we have venous collateral formings between the different hepatic veins. So we know very well that we have in almost half percent of the patient, we have an intrahepatic venous collateral with the diameter less than 1 millimeter in 73% of the cases. But in case of tumor occlusion or Budd-Chiari syndrome, we have enlargement of this collateral. So the key of this technique is the occlusion of this collateral. This is the result of the literature about this technique in terms of volume. We have a positive result. Just one paper published 2 months ago from Germany. So we have the same result in terms of volume between LVD and PVE. In the other paper, we have more gain with LVD than PVE. So, but all these papers are discussing the volumetry. So we try in our center to try to assess also the future remnant liver function with the scintigraphy, with the merbrophinin scintigraphy. So we perform this assessment at postoperative days 7, 14, and 21. As you can see on the right, we have, after liver venous deprivation, we have greater future remnant liver function than resection itself. We have almost 40% of future remnant liver function gain. So the results are very important. More important, the results are after that we called extended liver venous deprivation. So we perform the venous occlusion not only of the right hepatic vein, but also the middle hepatic vein. As you can see, we have a greater KGR, so we have almost 25 cc a day after extended liver venous deprivation. And if we perform a scintigraphy, as you can see, just after postoperative day 7, we have a sort of functional switch of the liver, especially of the future remnant liver. So it's difficult to explain why. We try to perform a histological examination of the future remnant liver of the liver with the metastasis. So we found a functional damage 2 times more important after liver venous deprivation than PVE. We don't know why, but these are the results. So to have a final conclusion, we need to wait our randomized control trial. This is national randomized control trial in France. We call HyperLive-01. We include 12 centers in France, and today 64 patients were included. So I try to analyze the mini invasive surgery impact in this 64 patients, including in HPB 01. So just a few slides just to show that the result of ALPS, you know that the major complication is death, and we have death after ALPS also in patients with strict volumetric criteria, because this is the key point. We have not a good correlation, between volume and function. So in this paper we published last year, you can see that we have insufficient function and adequate volume in almost 10% of the cases, and we have adequate function and insufficient volume in 14% of the cases. This is the key of all future remnant liver optimization technique. So, for example, in our center, we perform a major hepatectomy also in patients with insufficient volume, so less than 20%, but with good scintigraphy. So we try to analyze the difference of synthetic function between LVD and ALPS, and you can see the conclusion is that we have less alteration of synthetic function after LVD. So last year in France, this is the patient where this is not randomized control trials. So it was a retrospective series of different cancers. So they include also cascade tumor, ACC, and metastasis. So they concluded that LVD, we have a successful rate of about 72.6% versus 19% of ALPS. So we have a faster hypertrophy with ALPS, but in this study we have different weakness, the selection bias. This technique was different, so it's not standardized. So this is the result after the liver venous deprivation. Just this slide to show that that is technically demanding and sometimes require 2 or 3 hours. If we discuss the mini-invasive surgery after this technique, we need to consider the parenchyma congestion related to hepatic vein occlusion, the difficult to realize the intraoperative ultrasound because we have the glue, we have the vascular plug into the hepatic vein. So if we perform the intraoperative ultrasound, especially in laparoscopic, it's not easy. We considering also another parameters if there is more bleeding related to parenchyma congestion, if the duration is longer than open access, we have more hepatic vein collaterals or not, so more bleeding, and also we need to consider the hepatic vein plugs position. So during the protocol, we decide to change the position of the hepatic vein plugs because in mini-invasive surgery, we need to use the endo-GIA. If the hepatic vein is close to hepatic vein or vena cava, it's not easy to use this endo-GIA. So we decide to change the position of 2 centimeters to increase the possibility to realize the endo-GIA hepatic vein occlusion. So we decide to analyze our preliminary result in our HPB 01 trials. We decide to analyze different parameters about the mini-invasive surgery. So we have only 14 patients on 68 major hepatectomy performed laparoscopic. we have no case of robotic surgery. You know that in France, we have more than 220 robots, but many HPB surgeons in France still do the major hepatectomy in laparoscopic manner. So we have in our series, we have 14 patients performed laparoscopically, 7 in liver venous deprivation, and 7 in portal vein embolization, where all right hepatectomy. So we decide to analyze if there is some difference in terms of intraoperative bleeding, intraoperative transfusion, and operative duration. So as you can see, we have no difference in between open and mini-invasive surgery between about intraoperative bleeding and intraoperative transfusion. However, we have a longer operative time with laparoscopic than in open techniques. As you can see, this is the history of the hepatic vein plug. We just modified the technique, so we can close the hepatic vein with the endo-GIJ or also during the laparoscopic procedure. What about the oncological outcome? The same result in terms of overall and disease-free survival between mini-invasive surgery and open technique. So we have any difference between LVD and PVE. We have the same rate of post-hepatectomy liver failure, intraoperative bleeding, and bile leaks. We have a longer operative time in a mini-invasive group. Maybe with the robot, the results are different, but in our HyperLive-01, only laparoscopic procedure were considered. And we have the same oncological result in terms of overalls and disease-free survival. We wait the result of our HyperLive-01 French randomized control trial, and do you know the international Dragon 1 international randomized control trial. In the secondary endpoint, we have also the surgical approach. This is my take-home message. The slide on the right shows the volumetry of the functional remnant liver after post-operative day 7. On the right, the functional remnant liver scintigraphy with the mobrophanin at post-operative day 7. So liver venous deprivation is a valid and better alternative to portal vein embolization in our series of patients. We have 100% of successful rate in a colorectal liver metastasis, and mini-invasive surgery is feasible also in patients underwent to liver venous deprivation. Thank you. You are welcome in Montpellier.
Thank you very much, Professor Panaro, for your excellent lecture. Is there any questions or comment? If there is a question, would you please raise your hand to ask question to Professor Panaro? Yeah, Professor Troisi, please.
Sorry, I just put my question on the chat line. I'm wondering what are the thoughts of Fabrizio Panaro regarding the minimal invasive approach following LVD. I would say, is the LVD minimal invasive liver surgery friendly approach? Because we know that after dual embolization, the liver gets congested and the resection will be a little bit bloody. So I would ask him what he thinks about the preparation of LVD for laparoscopic or robotic second stage or first stage surgery by minimal invasive approach.
Thank you, thank you, thank you, Roberto, for this interesting. So we published a first paper in last year with Gianluca about the difference between LVD and PV in open surgery. There are no differences. So the data that I showed today are from the national, our national registry, our randomized control trial. The hypothesis of this study that we have, as you said, we have more venous collateral between the hepatic vein after LVD because we have hepatic vein occlusion, and we just know that we have a longer time and we have a tendency of more bleeding, but it's not significant because we have just 14 patients, so 7 patients in each arm. I think that if we have more patients, I think we have more bleeding during a laparoscopic procedure. So in our center is Professor Fabre that performed 5 cases, and we have more longer time because we need to better control this venous collateral after LVD. So I think with hepatic vein congestion we have more bleeding. And sometimes is a bleeding not easy to control laparoscopically. So we need to use the bipolar grasper every time, and sometimes with the clip or other devices is a little difficult to control. So in every time we use a Pringle technique. As you show in your segment 78, so we use a Pringle technique. We don't perform a continuous clamping in France. We perform intermittent clamping every 10 minutes, and I think it's feasible, but is a little bit more difficult during laparoscopic procedure.
Thank you very much, Professor Panaro. Actually, we have some question from the Dr. Farai, but we are just a little behind the schedule, so we will discuss it in the discussion time. I hope you're understanding. So the next speaker is Dr. Aslam Ejaz. Dr. Aslam Ejaz will speak with the title of Minimal Invasive Pancreatic Duodenectomy, Learning Curve and Outcome. So I think, yeah. Dr. Ejaz, can you start?
Yeah, if you can
Please.
stop sharing, then I can share my screen.
Dr. Panaro, would you stop sharing?
Yes.
Yeah, thank you.
I try, huh?
Can you see my screen?
Yes, Dr.
Okay,
Ejaz.
thank you very much. Thank you, Professor Hahn, Lillian, for the invitation to be on this wonderful panel here. So I'll be speaking about robotic Whipple, the operative techniques briefly, but mostly want to focus on the learning curve that we've experienced here at The Ohio State University. So just to start, I think this was a very seminal paper by Dr. Cameron, 2,000 consecutive Whipple operations, and I wanted to highlight the different outcomes. And so the mortality in this 2,000 consecutive series was 1.6%, but morbidity was still high, as we all know, for Whipple operations, and this was at 45%. The length of stay improved over time, and it was only about 10 days in the 2000s. And so even with open Whipple operations, as we know, there clearly is a learning curve that we experience over time. The largest, earliest robotic Whipple experience was from Professor Giulianotti, who reported on 134 consecutive robotic Whipples with a median length of stay of 9 days compared to 10 in Dr. Cameron's series. And the postoperative morbidity was reported as 26%. And so that really showed the safety, feasibility, and efficacy of using the robotic platform for the Whipple operation. Now, there have been several studies that have attempted to compare a robotic versus open approach for the Whipple operation. This was a multi-institutional comparison using propensity score matching. And the patients who underwent a robotic operation were higher risk. They had a higher BMI, more often had previous surgery, and they often had softer pancreas, which put them at increased risk for postoperative pancreatic fistula. What they found was, after matching, that there was a longer operative time with the robotic approach. However, there was suggestion of reduced blood loss as well as reduced major complications. There was a meta-analysis in 2017 looking at the different studies that compared robotic versus open operation. And operative time, again, was longer for the minimally invasive approach. However, blood loss and overall morbidity seemed to favor a minimally invasive approach. In 2017, there was another national study using propensity score matching. And this is comparing the postoperative pancreatic fistula. And what they found, again, was that the robotic approach seemed to have less chance of developing a postoperative pancreatic fistula. And so, as we all know, there's several advantages of just a minimally invasive approach, whether it's robotic or laparoscopic. Obviously, the smaller incisions, potentially less pain. What we've been studying here is less opioid use using the minimally invasive approach. There's some suggestion of decreased length of hospital stay, as well as decreased time to functional recovery. And at least personally, the advantages that I believe are of robotics over laparoscopic approach, obviously the endo-wrist movements, easier suturing. But what I believe is probably the biggest benefit is that a robotic approach is more generalizable to more surgeons. And as was shown earlier, the robotic approach has really taken off. And I've performed both laparoscopic and robotic operations, and I think the robotic approach, particularly in the reconstruction, generally has significant advantages over the laparoscopic approach, and again allows more surgeons to be able to do the Whipple operation in a minimally invasive fashion. There are disadvantages, as we've seen. There's increased operative time, increased cost, and although the few studies that I've shown that may suggest a decreased postoperative fistula rate, there are some studies that show that there's an increased rate. A lot of this, I believe, is probably due to patient selection. I think, as I showed earlier, the patients that are selected for robotic approach tend to be higher risk. And perhaps probably the most important thing is the learning curve. And this has been mentioned earlier with minimally invasive hepatectomy. And so clearly there is a learning curve for robotic Whipple operation. So our robotic Whipple program was started in 2016 and since has grown quite a bit. We took a little bit of a hit during the pandemic as we tried to minimize our robotic approach for various reasons. But this year we're slated to perform well over 200 cases. This was a report from 2019 that attempted to assess the learning curve of robotic approach. And what they found was that in terms of operative time, that it really did not plateau until over 100 cases. Similarly, for different outcomes, such as blood loss, pancreatic fistula rate, the learning curve seemed to plateau around 100 cases. This was a study from the Pittsburgh group, and they found different number of cases to achieve proficiency, depending on which outcome to look at. So if you look at the bottom left, they identified 3 separate phases for operative time at 80, 140, and 200 cases. In addition, EBL, estimated blood loss on the top right, and pancreatic fistula, they similarly found that there was a high number of cases that needed to be achieved to achieve optimal outcomes. So we took this and in our experience, we attempted to mitigate the learning curve, and not necessarily to eliminate it, but to try to accelerate it and to try to achieve a proficiency much faster than 100 cases. And so this is our curriculum here. And this curriculum was used obviously for the faculty. I participated in a similar curriculum during my residency and fellowship. And now currently, we also use this for our fellows and residents when we train them on the robotic platform. And so in addition to the virtual simulators, we had a biotissue anatomic curriculum, and we made sure that we achieved proficiency in the lab prior to performing any cases. Our approach is similar to other reports. We use a standard robotic approach with 4 ports. The camera, we always try to position just to the right of the umbilicus. In terms of the dissection, the most important portion, as we all know, is the uncinate dissection. And we really try to achieve the camera to be directly in line with the uncinate to achieve optimal visualization. We previously used to use a liver retractor. However, we've shown that this is likely not needed in most patients. And we use 2 assistant ports for both retraction, suctioning, as well as some stapling. So as I mentioned earlier, I think the robotic approach really has benefits during the reconstruction phase. The ability to have the endo-wrist movement allows for more precise suturing. And I just wanted to show a very quick video of our technique for the pancreatic ogygenostomy anastomosis. We generally use a modified Bloom-Guard approach. And so we place the transpancreatic sutures. And then this here is our duct to mucosa. We generally use 5/0 PDS, but it depends on the size of the pancreatic duct. But again, the visualization and the endo-wrist movements, at least in my opinion, is definitely more precise using the robotic approach compared to the laparoscopic approach. Here we're tying the duct to mucosa sutures here, and then we complete it with our anterior row of sutures from capsule to the bowel. And this is the completed anastomosis. So again, it allows us to complete this anastomosis quicker, and I believe with more precision. So we briefly looked at our early experience with our learning curve, and we have since updated this and compared this to a more modern series. But what we found is that there was clearly a learning curve early on, but it appeared to be much less than the reported 100 cases. Our operative time significantly decreased. Again, as I mentioned, I believe this is a combination of the training that we performed prior to and our preparations prior to performing our first case. As in other studies, we looked at surgical failure, which in this study was defined as conversion to open, any grade 3 or more complication in the postoperative period, or any blood transfusion. And as we see here, that there was really no identifiable learning curve. We then performed a propensity score matched comparison between our most recent open operations and our robotic operations. And similar to other studies, as we found that the operative time was longer. However, the major complications and other perioperative outcomes were similar between robot and open. So again, I believe there clearly is a learning curve, but as I show on the right-hand side, in our attempt, we attempt to mitigate the learning curve or shorten the learning curve by making that curve more steeper rather than longer. So in conclusion, I believe the robotic platform is a tool, and I believe it helps facilitate minimally invasive surgery, particularly for the Whipple operation. It's clearly has been proven to be safe, and there are ongoing studies and studies that should measure different ways to assess the benefit of the robotic platform. As I mentioned, in combination with our enhanced recovery protocol, we've seen that the robotic platform is essentially an opioid-sparing operation. Time to functional recovery, patient-reported outcomes and quality of life measures, as well as cancer-specific measures. We're assessing at the molecular level different indications of inflammation and surgical stress and how this compares with a robotic approach compared to open, as well as other cancer-specific measures such as time to adjuvant therapy and disease-free survival. So thank you very much again for the invitation.
May I ask you something, Dr. Aslan?
Yes, please.
Thank you for your lecture. I guess your series is institutional series where more than one surgeon is performing the procedure. Did you analyze how many Whipple procedure do you need to reach the mastery phase? If there is a difference between the surgeon, because we have a lot of cases. And secondly, how do you select the patients? I mean, do you perform also vascular reconstructions, or are you operating in robotic patients after neoadjuvant treatments?
Great question. Thank you so much for those questions. I'll answer the second one first. So in terms of patient selection, early on in our experience, at least for the first 50 to 75 cases, we operated on clearly resectable patients. We did have majority of our patients do receive neoadjuvant chemotherapy here at our institution, even for resectable patients. For borderline and locally advanced, we use chemoradiation, and that's selective currently. So early on in our experience, we were definitely had some patient selection trying to operate on the quote unquote easier tumors. So that clearly is seen in our results. For your first question, there are 3 surgeons here. And it's a little bit difficult to differentiate between the different surgeons. For the majority of the operation, it's done by a surgeon and a bedside assist, which is either a fellow or a first assist. However, for the uncinate dissection, we oftentimes have 2 attending surgeons, one at the robotic console and one at the bedside. So that's a great question. We haven't looked at specifically the individual surgeon. We know our overall outcomes, but that's something that we can definitely look at to see if there are different proficiency rates, depending on the surgeon.
Thank you.
Thank you.
Thank you, Dr. Ezas, for excellent lecture. Thank you very much. And we move to next speaker. Next speaker is my friend, Dr. John Martini. He will speak about robotic for gallbladder cancer. Dr. John Martini, please.
All right, let's see. Can you see my screen?
Not yet.
Okay, let's see. Okay. All right, how about now?
Yes, I can see now.
Okay. All right, let's see if I can get this up and running. I apologize, this is a... How about that? Can we see my screen?
Yes.
Yes.
Okay, good. Thanks very much. Thank you, Professor Hahn, for the invitation. This is a very brief, this is going to be 10 minutes or less. So I was asked to talk about gallbladder carcinoma. I do have disclosures. I do a lot of teaching for Intuitive and some other companies. To begin with, briefly, gallbladder carcinoma varies incidence across the the globe, higher incidence in Asia and South American countries. A relatively uncommon problem in the United States, although we do see about somewhere around 5,000 cases of gallbladder carcinoma in the US annually. Obviously the survival for gallbladder carcinoma is rather dismal. I would say certainly less than 19% as on this slide. And there's a variety of presentations of gallbladder carcinoma, and I think it really is a very complex talk to give. First of all, gallbladder carcinoma found preoperatively, that is, with a mass in the gallbladder on imaging that gets sent to me, is actually the least common for me to see as a surgeon. Usually, I either get a phone call from a general surgeon who's doing an operation and they find a mass in the operating room that is intraop, or the other common presentation would be post-operative diagnosis that is found pathologically unexpected. And so those are the two more common presentations for my practice. And I'm going to focus on the latter. I'm going to focus on really what do you do with the post-operative patients who get sent down to your clinic. Patients who are seen obviously with a mass in the gallbladder, or a lot of times in the liver near the gallbladder growing into the gallbladder carcinoma, it's often difficult to distinguish gallbladder cancer from cholangiocarcinoma. And the survival obviously depends on the workup. So the workup for these patients are very, as you can imagine, exhaustive. So we CT scan and MRI of the liver, CT chest, tumor markers. We do a lot in the United States, I would say, and in academic practice, we do a lot of extensive workup, which includes endoscopic ultrasound to look at the portal nodes, to look in the invasion into the hepatoduodenal ligament. Sometimes that includes ERCP, and PET scans are commonly used in the United States for this. Masses that we intend to perform neoadjuvant therapy on, they all get staging laparoscopy prior to initiation of therapy. Now, gallbladder mass found at the time of surgery, that is in either planned cholecystectomy or other procedures, the first thing we try to teach surgeons is call an expert, call an HPB surgeon who's seen that and done that. And we would actually tell patients or tell surgeons, if you have a mass, you find a mass at the time, and you're a small hospital, you don't have the anesthesia support, you haven't consented the patient for a liver resection, the best thing you can do for that patient is to abort the operation. And I really think that's the best thing. Send it for staging, get some biopsies and things like that. The worst case is when a surgeon is doing an operation for a gallbladder that appears to be just an inflamed or stuck gallbladder, and they convert to open, and then they proceed to disrupt the gallbladder gets morcellated, and then all of a sudden we find that the patient has a poorly differentiated cancer, and now the tumor has been spilled all over the abdomen. And I could tell you, I see one of those probably every other year as a referral. That's obviously a horrible thing for the patient. The incidental carcinoma found post-cholecystectomy, again, these are the smaller T1, T2 tumors, maybe sometimes a T3 tumor. Workup is similar. So we work these up with CT and MR, chest CT, tumor markers. PET scans are commonly used. And obviously, it's important to get the pathology from the outside facility and the op note. Now, what about upfront resection? Again, I'm gonna focus on the patients who have already had surgery. They've already had their gallbladder removed rather than the de novo liver mass. So what do you do with the patient shows up in your office? I think it really matters on the patient. So patients who've had a relatively uneventful laparoscopic cholecystectomy, who have relatively small lesions found on pathology. These are T1 or T2 tumors, and they don't have any obvious metastatic disease. They don't have bulky nodal disease, and they have a negative PET. These are the patients that go essentially right back to the operating room, and we perform a robotic staging and completion operation. And I'll show the video of that, essentially what we do. The harder cases are the one that I described where the surgeon had attempted a gallbladder operation and they converted to open, and they had a horrible case with disruption of the gallbladder wall and tumor spillage and stones and everything. And those patients come to me, usually they're 3 or 4 weeks out from their operation. They've got a big right upper quadrant subcostal incision. They're just recovering from a big operation. And then they come to me and they expect me to fix them or cure them. And you know that those patients have had tumor spillage throughout the abdomen. Sometimes there's part of the gallbladder wall left in on the liver. So there's gross, those are the patients. I don't take those patients back to the operating room. And in fact, the patient I remember was a patient who was a Jehovah's Witness who had gross residual tumor, who came to me 3 weeks out with a subcostal incision who's healing. And then the oncologist wanted me to take the patient back to the operating room. And I said, no, this patient is going to get 3 months of chemotherapy. And so we started, this is probably about 10 years ago, we started doing this. So before there was any data. So these patients now are all treated up front with appropriate staging and 3 months of at least 3 months of chemotherapy, followed by then a surgical re-resection after restaging. And so anybody who has on imaging bulky nodes, they've got a big tumor, they had extensive tumor spillage or gallbladder disruption, those are patients who are going to get neoadjuvant therapy. Okay. So the surgery now that we do after all that, if they come back 3 months later and the plan is for re-resection or restaging, whichever you want to call it, or these are the patients with the T1 or T2 tumor, this is what we essentially do nowadays. We start with obvious laparoscopy. I had one of these not 2 weeks ago, and we put the scope in, and what do they have? She had diaphragm peritoneal studding. So the operation is over, and that's just a testament to how bad this cancer is. So we start with a laparoscopy. I usually start with a node dissection, and so I typically start like I do for a Whipple or a liver resection. I start with station 8 lymph node. So we open the lesser omentum, pars flaccida, station 8 lymph node, and then we do all the medial portal lymph nodes at station 12 and 12A, and then we do the lateral portal nodes, and then we cochorize the duodenum and do the posterior duodenal nodes. So all those nodes, if those are grossly positive, then you can make an argument there's no benefit to the patient of doing anything further. But we then go to the lateral aspect of the bile duct. I almost always re-resect the cystic duct stump, and if there's any residual disease there, if the neck margin is close. To be honest with you, I've not had a case where I needed to resect the bile duct, because in those cases, usually there's more tumor that's extending, involving the entirety of the hepatoduodenal ligament, and those patients are non-curative. And then the liver resection, again, this is tailored. We usually do essentially a disc resection or a radical resection of the gallbladder fossa or the plate. Sometimes if there's gross tumor that's recurred or was residual in the gallbladder fossa, that'll mandate a sort of a tangential resection of the colon or the duodenum or the omentum. And so we've done some of those as well. If there's tumor outside of the gallbladder fossa, though, that to me is metastatic disease, and that's not curative. So we don't do those. It's only if there's this limited disease in the fossa. And that's essentially how we do. And of course, we use ultrasound, we use ICG and all that stuff. So obviously, this is all done robotically in my practice. I do have 2 partners who do not do robotics, who are still doing old-fashioned laparoscopy, and so most of their gallbladder cancer cases are in fact open for a reason, because they can't do the extensive portal lymphadenectomy that we do with robotics. And I'm happy to debate that. I'll show you some data on that. We obviously, during the inflow control, we do selective inflow control. So this is a brief video in the sake of time. So again, you can see here, this is starting along the superior border of the pancreas. Pars flaccida is open. It's usually we need to mobilize the stomach to expose this area. We need to take the right gastric artery is usually divided here, as you can see. And I almost always use the robotic scissors for my dissections. rather than the hook. And again, you could use the hook here, but I just love the scissors. So you can use it as a dissecting tool. You can use it to hook and burn, and you can use it to do all of this dissection. So this is station 8 lymph node. This looks like a pretty unremarkable lymph node. So, you know, this would not go for frozen section. We would only send it for frozen if I was really worried that I had bulky disease. So you can see this is the dissecting up towards the celiac bifurcation. So we take these nodes right off of the left gastric or the coronary vein. And it's important to do what I call a comprehensive lymphadenectomy. This is not just cherry picking, which is what is often done in videos that I see and review. So this is a hepatic artery and the window between the hepatic artery and the portal vein. And all of these lymph nodes need to be mobilized, the posterior nodes. You can't just take the anterior nodes, because as you know, gallbladder cancer typically goes behind through the duodenal nodes. So more dissection. So these are all the station 12 nodes, the posterior nodes, and we ultrasound, do a lot of ultrasound for these kind of cases, making sure you've got all the nodes, then taking the posterior nodes. In this video, I didn't show the re-resection of the cystic duct stump, but that's almost always done for pathology. And then we do, this is what I would call a radical cholecystectomy. We're taking about 2 centimeters of liver parenchyma outside, staying outside of the gallbladder fossa. If there's any omentum that is stuck, you leave that attached so as to not disrupt anything. And as I mentioned, so this is not truly a 4B5 resection because we're not doing an anatomical segmentectomy, but this is re-resection of the bed, and that's how we do that. Now we looked at our series of robotic gallbladder and match these to open at our cases. We submitted this for publication. We had a group of laparoscopic gallbladder cancer operations. There was about 6 or 7 of them, and they were just terrible in terms of outcomes. So we actually eliminated them from the study. But this was 20 gallbladder cancer reoperations compared with 23 opens. As I mentioned, and if you see here, the main thing was the length of stay. So there's a big difference in terms of length of stay, and all other outcomes were pretty similar. I would point out, actually, there was a trend towards higher lymph node yield in the robotic arm. And the reason is because from that video, I pay attention to the nodes. I'm not just going in and plucking out 1 or 2 nodes. So I actually do a very comprehensive operation. So doing it with the robot actually changed how I do that. All the other outcomes are generally speaking driven by the oncologic biological behavior of these tumors, which is fairly dismal. And nevertheless, you can see outcomes, and that's our mortality. So I would say, again, gallbladder cancer, there's different ways of presentations, and you have to tailor your approach. I would tell you that for me, in my practice, robotics essentially has eliminated the need of doing any of these cases open, which is really nice for those patients, as I mentioned, who come with a big disaster open cholecystectomy, incision, and healing, and you can now do these operations without having to reopen them. So I think it's a big advantage to the patients. And I know that, again, there's more and more use of the neoadjuvant approach. Technically not totally neoadjuvant because they've already had a cholecystectomy, but I would say I would use the neoadjuvant, the chemotherapy prior to the re-resection. And so with that, I'm happy to take any questions at the end during the discussion phase. So thank you very much for the invitation. And I think I gave the screen back to Lillian.
Thank you, Dr. Martini, for your excellent lecture, and also
Sure.
sharing a very beautiful video. So,
Sure.
Roberto Troisi, please.
John, thank you
Yes.
so much.
You're welcome,
Clear
sir.
lecture and video. I would say that okay, for you, robotic surgery changed the approach from open to minimal invasive. We did in Seoul 3 or 4 years ago, let's say a meeting on gallbladder cancer and approach with laparoscopic resection. And we noticed that laparoscopic HPB surgeons are capable to do appropriate lymphadenectomy and to do what you show for T1, T2 gallbladder cancer type operation. I mean, for this kind of operation, robot is just a matter of preference, because I agree with you that we can do nicely the lymphadenectomy, but even by laparoscopy you can do this. Of course, you have to pay attention. You should look to the lymph nodes, but if you don't speak about bile duct reconstructions, if you are looking to bile duct reconstruction, I will do robotically, not laparoscopically, because I'm sure I can do the same as in open surgery. But if we stick just on T1, T2, 2-centimeter gallbladder fossa resection and lymphadenectomy, a good HPB laparoscopic surgeon can do similarly as by the robot.
Well, I would say you're being rather generous, because I've seen my partners try to do this laparoscopically, and it's very hard for them with the straight, like using a ligature device or something, to get the posterior nodes, that is the nodes stuck behind the hepatic artery and the portal vein. It's just a difficult angle to get. And that's why we actually threw the laparoscopic cohort out of that paper, because it was terrible. I mean, they were just cherry picking 1 or 2 nodes, and they're not getting, the posterior duodenal nodes. So to say that they can, they can, but they don't, so they're just not doing it. And I would say that's the unspoken truth. And when you go to meetings and you hear people talk about, oh, I can do a laparoscopic Whipple, and you watch their video and it's terrible,
That's why I never attempted to do a Whipple by lap, because I was sure that my jest was not appropriate.
Yeah. So
but with the robot, there's a different story.
Yeah, you can, but it's just the nodes, getting those posterior nodes, the duodenal, co-horizon duodenum, taking the nodes behind the portal vein. Those are just hard to get. And when I watch my partners who are very good laparoscopic surgeons, but they're just not doing it the same. It's not the same.
Mm-hmm.
Oh, thank you, Dr. Martini. Yeah.
Thank you, Dr.
Very good.
Hahn.
Yeah, thank you. Anyway, as you said, the laparoscopic lymph node dissection need more experience. I think that's why I think if the surgeon starting to use minimally invasive surgery for gallbladder cancer, I think as Professor Martini already mentioned, I think a robotic approach may be a good choice. Anyway, as Professor Troisi already mentioned, if we may have a good experience of lymph node dissection, I think laparoscopy can be a good choice. But still, as I said, it needs more experience. So we will move to next speaker. Next speaker is Dr. Kaufman. He will speak. Dr.
I share the presentation.
Yeah.
I share the presentation.
Yeah.
Just tell me if you hear the volume.
Dear colleagues and friends, I apologize.
Yes, I can hear. Good.
But I'm glad to share with you what I have learned from our initial experience with 500 robotic pancreatic resections. I have no conflict of interest to disclose. Overall, we have performed over 600 minimally invasive pancreatic resections. As you can see, most of these minimally invasive pancreatic resections were performed robotically, and most of our robotic resections were Whipple procedures. Overall, during the past 14 years, we have performed 17,000 pancreatic resections, roughly 1/3 were done minimal invasive, and 30% were done under robotic assistance. When we look specifically at the minimal invasive pancreatectomy with vascular resection, you can see that we have done 62 of such procedures. This included a vein resection in 53 operations, an artery plus a vein resection in 4 operations, and an artery alone in 5 operations, and therefore a total of 62 procedures. This table here shows that we never use conventional laparoscopy techniques for a robotic pancreatectomy with a vascular resection, but we predominantly use robotic assistance for a total pancreatectomy with an associated vascular resection, while we quite liberally use conventional laparoscopy techniques for a distal pancreatectomy with an associated vascular procedure. But to be honest, this was not done because of a preference for conventional laparoscopy, but because the robot was not available for that procedure at that specific time. And finally, this table here presents the type of vein resection according to the International Study Group on Pancreatic Surgery, so type 1, type 2, type 3, and type 4. What is worth to mention here is that many of our resections were type 3 and type 4, so namely they were segmental vein resections. The study was published in 2013. It was about feasibility of robotic pancreatoduodenectomy. Based on 34 procedures that at that time were roughly 15% of our pancreatoduodenectomies, we showed that the procedure was feasible. We also included few cases with vein resection. Mean operative time was really long, around 10 hours, but there were no open conversions. Additional results from this study showed that really the technique was feasible. The results were quite clinically good, but unfortunately there was a high increase in operative cost, exceeding those of the open procedure by over 6,000 euros. Our next study was on the learning curve in robotic pancreatoduodenectomy. As you can see here, based on operative time, we estimated that 33 procedures were required to complete the learning curve. Once this was done, we saw a decrease in the rate of delayed gastric empty and reduced rates of hospital readmission. In a further study, we subsequently reported the results of our first 200 robotic pancreatic resections. As you can see, most of these were pancreatoduodenectomies or distal pancreatectomies. Again, the results were quite good. As you can see here, we had 0.5 mortality at 30 days and a 90-day mortality of 1%. In this study, we showed that for both pancreatoduodenectomy and distal pancreatectomy, operative time decreased with experience. During this early experience, we could not see an increase in the proportion of patients receiving a robotic versus an open procedure, but for the distal pancreatectomy at the end of the study period, we basically had an overlap between the proportion of patients undergoing open and robotic distal pancreatectomy. In this study, we could also make a comparison between robotic and open pancreatoduodenectomy. Indeed, 36 patients who were initially selected for a robotic approach actually had an open operation because the robot was not timely available. Statistically significant results are highlighted in yellow. What is most important to note is that an open procedure is associated with a shorter operative time. The other differences are really small, and basically the two procedures were equivalent from a clinical point. Our next study was on 112 robotic pancreatoduodenectomies, and once more, the results were quite satisfactory. At that time, we have roughly a 3% of conversion rate to open, 8% of vein resection. You can see that operative time already decreased by 1 hour. We had a quite good 90-day mortality, roughly around 3.5%. What may be worth to note is that the low rate of grade C postoperative pancreatic fistula at that time was around 2%. In this additional study, we reported our first 13 procedures with a vascular resection. As I said already before, most were type 3 and type 4, so segmental vein resection. It may be worth to note that there were no conversions to the open procedure, and the long-term vein thrombosis was around 8%. This is a study in which we compare robotic versus open pancreatoduodenectomy based on a prospective score match analysis based on factors predictive of postoperative pancreatic fistula. What is key to discuss about this study, as shown in this slide here, is that to run a prospective randomized study, really were to be done based on, I would say, on statistically some material, you would require an enormous amount of cases, showing that by definition robotic is equivalent to open for incidence of postoperative pancreatic fistula. The same were done for MAGI statuses. Once more, to run a meaningful prospective randomized study would require over 3,000 pairs of patients, showing that by definition, again, robotic is equivalent to open. This is a study that we publish on how we do modified balloon wire anastomosis during robotic Whipple. As you can see in this patient with a small dot, we place an IV cannula into the basin dot, and then we place 2 mattress sutures above and below the basin dot, just to close the pancreatic parenchyma. Next, we use 2 sutures of EPTFE placed at the mesenteric border of the jejunum, and then we pass those 2 sutures transparenchymally on the pancreas above and below the basin. Then a 3rd suture is placed, a mattress suture is placed behind the basin dot. When this is tied, we open the jejunum and we start performing a adaptive mucosa anastomosis that usually is done using uninterrupted 5-0 PDS sutures. As you can see here with the robot, you can really precisely place the sutures, and my impression, my feeling is that I could not do this better open. Actually, my feeling is that I'm doing a bit better using robotic assistance. This is a small dot. You see, you can still quite precisely place the sutures. And this patient here, we decided to use a dot stand. Actually, this is not our standard. We basically don't use a dot stand as a routine. And this patient here, we probably placed the stand to facilitate construction of the anterior row of the adaptive mucosa anastomosis. But at the end, as I said, I don't really believe that there's a great difference from a practical point of view. It's just a technical issue. I don't really believe that the dot stand can prevent a pancreatic fistula. Maybe it could a little bit be a mitigation of that. You can see here the stand. And then we go completely the anterior part of our adaptive mucosa, still with this uninterrupted 5-0 PDS sutures. Once this will be tied, you will see this shortly. We can go completing the external layer by placing two additional sutures at each corner of the anastomosis. This is the one placed above at the superior corner. You see, you still take the pancreas transparenchymally, and then you place 3 stitches on the jejunum in an attempt to make a kind of half-pushing suture that, once tied, will wrap the jejunum over the corner of the pancreas. This is placed at the superior corner. This is at the lower corner. Exactly the same thing. We have already placed the stitch on the pancreatic parenchyma. We're now placing on the jejunum. Next, we place a mattress suture above the pancreatic, that anchoring the jejunum to the pancreatic capsula. Once these sutures are tied, the anastomosis is done. More recently, we describe how we do the hepatic jejunostomy, either during a robotic or an open procedure. You can see here a video from a robotic procedure. The basic principle is that we always do a double layer running suture. The key features is that in all external layers, either anterior or posterior, we try not to go to full thickness of the common bile duct. Putting this into figures, you can see here we have an extremely low bile leak rate, approximately 0.6, and the reasonable rate of redo hepatic jejunostomy, approximately around 6.1%. This technique has always been done since, I would say, ever at our institution. Now we have used this also in the robotic approach, and the results are so good that we don't feel necessary to go for a different procedure, such as using uninterrupted sutures. In a very recent study, we showed the feasibility of cold triangle pancreatoduodenectomy. The rationale for that approach is that the triangle space contains viable cancer cell in approximately 80% of resected pancreatic cancer. The principle of cold dissection is doing everything by scissors, not using any energy device, trying to ligate as much as possible. You can see here these two photographs showing a ligature of a lymphatic channel. As you can see here in this photograph, we still use scissors when we go to divest the right side of the superior mesenteric artery in order to try to avoid any eating damage to that artery. This video here shows on practical terms how we do it. So you can see here, this is a common hepatic artery, and we go around that with a vascular loop, and then we start doing a divestment. So not just nodes, but more importantly, nerves that are frequently invaded by pancreatic cancer. And we go down the common hepatic artery until the celiac trunk is encountered, and again down on the anterior aspects until the right diaphragmatic cruise is reached. As you can see here, we really do not use any energy device. We try to clip or ligate everything. It's a little bit tedious, you can understand, but we really struggle to avoid thermal injury to those visceral vessels. We have just seen the right diaphragmatic cruise. Here another lympho-neural bundle that is clipped and divided. Then we elevated the hepatic artery, and we proceed in the same manner on the right side of the celiac trunk, again down until the right diaphragmatic cruise is reached again. Next, a white-cocked maneuver is performed. At this time, an harmonic scalpel can be used since there are large vessels at this level. But once you approach the superior mesenteric artery and the celiac trunk, we go back on to the cold dissection. You can see here in the background the superior mesenteric artery that becomes visible. We are dividing the lympho-neural bundles at that level in an attempt to do some kind of centripetal neuro lymphadenectomy, closing, if I may say, the tumor into an envelope. You can see we are elevating everything, doing this centripetally, and you will see shortly now it is, we can see the celiac trunk and the superior mesenteric artery. This additional short video clip shows how we divide the mesojejunum and the first jejunal lobe. As you can see, we open the posterior peritoneum, then we pull the first jejunal loop to the right side of the superior mesenteric axis, and we start dividing the mesojejunum. Our aim, especially in tumors from the uncinate process, is to keep the first one or two jejunal branches. By doing this, we can remove some jejunal nodes that sometimes are involved, and we have a better approach and a safer lymphadenectomy of station 14. This last video clip shows how we really do the final part of the dissection. You can see here the superior mesenteric artery. This is the inferior pancreatico duodenal vein that is being ligated using linen, which is our preferred suture material for this purpose here. You see it is ligated, divided, then we place an hemolog for extra safety. When this is done, we proceed along the right margin of the superior mesenteric artery on the back of the superior mesenteric portal vein axis. This triangular space here is like the axilla of the pancreatic head. And once again, it is not just about removing nodes, it's about removing nerves. If you have a recurrence from a pancreatic cancer, you see it around the arteries like a gray halo around the arteries. These are nerves that are full of cancer cells. So what you are removing here, again, is not just nodes, it's not just lymphadenectomy, it is neurectomy. By doing this, should publish this hopefully shortly, we were able to dramatically reduce the incidence of local recurrence. Once again, everything is done cold. You go down by scissors. You try not to have any thermal damage to these vital arteries. You can see here the superior mesenteric artery and the celiac trunk hepatic artery. We keep doing this until everything comes in block with the specimen. which is often very nicely done. And at the end, you will see it shortly, there is no left tissue around this artery. This makes the occurrence of a local recurrence very unlikely. These are brand new results. You can see here that during the last 10 years, basically we've done approximately 150 pancreatoduodenectomies with the vein resections. This included 115 open pancreatoduodenectomies and 36 robotic pancreatoduodenectomies. As you can see at the baseline, before any propensity matching, the two groups were different by patient age and median ASA score. Again, in the unmatched population, as you can see here, robotic pancreatoduodenectomy with vein resection was associated with longer operative time and with more frequent use of junk graft for vein reconstruction, and with a trend toward shorter length of hospital stay. For the remaining parameters, the remaining clinical parameters were all equivalent between open and. As shown in the slide, histology showed no difference between the two groups. Following propensity score match, we were able to compare 35 open versus 35 robotic pancreatoduodenectomies with vein resection. As you can see here in the slides, the two groups were well matched. From a clinical point of view, the two groups just different for operative time, which of course was longer and actually quite long in pancreatoduodenectomy with vein resection. For the remaining clinical parameters, the two groups, even if not matched, were equivalent. Again, pathology parameters were similar and no difference was detected between open and robotic pancreatoduodenectomy with vein resection. This video presents a type 1 vein resection reconstruction during robotic pancreatoduodenectomy. In this patient here, the tumor was too close to the origin of the superior pancreatoduodenal vein, so I decided to take a small piece of the side wall of the portal vein to increase the probability of achieving an R0 resection. As you can see, I used the 4 robotic arm as a vascular clamp, and I perform a running vascular suture using a 5-0 polypropylene suture. The repair was quite straightforward, and actually I do not increase that these small side wall resections with primary repair actually increase too much the risk of these robotic pancreatoduodenectomies. Once you construction performed during a robotic pancreatectomy, since you have to reset a larger patch here, you need a suture to take a measure of the size of the patch that you need for repair. Once you are ready, you cross clamp everything. Here the superior mesenteric artery, then the splenic artery to reduce blood congestion into the spleen, then the splenic vein, the superior mesenteric vein, and last the portal. Then you're ready to open your vein. Here it is a very large patch, so a very large breach you can see here. And you have not to try to spare some vein because you are taking a tumor, so you must be radical. Then here I place a suture to improve exposure of the breach. And in this case here, we have the availability of a large arterial patch, actually a disease donor arterial patch, which is quite wonderful, quite ideal. You see it provides a nice exposure because it does not collapse as opposed to a vein. You can see how nicely you can look at the posterior row of your anastomosis while this is being constructed. And the good part of this, of the use of this arterial patch when it is available, of course, is that it also provides a nice support to the reconstructed vessel at the end. This type of large side wall resection is particularly suitable when the infiltration involves the junction with the splenic vein, because in this way, you reconstruct the superior mesenteric portal vein, you don't need to reconstruct the outflow from the splenic vein. At the end, there is actually no bleed. You just need to fix a small bleed with a single interrupted suture of polypropylene. start by cross-clamping all the vessels. Here we have cross-clamped the SMV below and above the tumor. Then we take the segmental piece of the superior mesenteric vein, and we go for a direct reconstruction, again using an EPTFE suture starting from the left corner. You see, we start approximating the sutures. The posterior row is performed from inside. We never face any issue by doing that from the inside, either open, laparoscopic, robotic, cabinani. There is no issue. And the suture is done like in an open procedure, like in a conventional procedure. So you start doing your suture at one corner, you start at the other corner, then you start with another suture. And once you join the first suture, you will tie, of course, the sutures together by leaving a small growth factor. The same growth factor that started originally described some 30 years ago for the liver transplant, that is meant to prevent the thrusting effect that otherwise could result from around the suture. You see, we are almost done. We flush the vein, we complete our suture, and then we tie the two sutures together by leaving a small growth factor. You will see shortly that's the small growth factor that we are leaving. You see, I'm also trying to be sure that there is a growth factor, and at the end we perfect the hemostasis with some anti-radical sutures as needed, but it can be done. It is usually nicely done. This week, keratoduodenectomy. You can see here we start by cross-clamping the superior mesenteric artery, then the superior mesenteric vein. The superior mesenteric vein is closed distally by a hemolog cleave, and this way you can have some blood flow going through the splenic vein into the portal vein, thus maintaining some kind of blood supply, portal vein supply to the liver. Here it is the jam graft that is introduced into the abdomen. We start our proximal suture using this EPTFE suture, which is Gore-Tex, which is quite suitable for the pancreatic suture, the robotic suture. Then once the proximal anastomosis is performed, we cross-clamp everything and we go for the distal anastomosis. Here we have, you see, to replace a quite long segment of the superior mesenteric portal vein. So you do your distal anastomosis still using this Gore-Tex suture. Then in this patient, we decided to implant the splenic vein and to side on this jam graft. You see here we unroof the jam graft, and then we start doing our anti-slab anatomy. So you see, using the robot, you can suture quite well. This is not too much stressing. I would say it's quite easy if you are in a control situation. Before removing the clamps, we flush the vein, then we start removing the clamp on the portal vein as the splenic vein, and then the superior mesenteric vein, lastly, superior mesenteric artery, and this is the final picture. Conclusions, ladies and gentlemen. Robotic assist permits all types of commonly performed pancreatic resections. The main drawback of this device is the high cost that remains the main limiting factor. Based on limited availability of the robot, our institution, we are allowed to use it just once a week. We now almost reserve that for a pancreatoduodenectomy. However, I have to admit that it could be an extraordinary tool also for other kinds of pancreatic resections. Once more, I apologize for not being there. It was an honor to be invited. I will be happy to reply to your questions.
Yes, this is a very excellent video. Thank you very much. Although Dr. Ugo Bozzi is not here, I appreciate that. And Dr. Kaufman, please say our the appreciation to Professor Ugo Bozzi.
Yes.
Yeah.
Of course, thanks.
Yeah, and we have some general introduction by Lilian. So Lilian, can you speak for general introduction, Lilian?
Yes, a moment, please. 视频又开始，我等一下空。 Okay, can you see my screen?
Yes.
Okay, perfect. So I'm gonna make a brief introduction of our journal. So minimally invasive surgery, our editor-in-chief is Dr. Guoliu Bailey, and our honorary editor-in-chief is Michelle Ganner. And here is the general introduction of our journal. Minimally invasive surgery is an international peer-reviewed and open access online academic journal. So the journal published original research articles, review articles, editorial commentary letters to editor, and technical notes. So images and videos about novel minimally invasive technologies are also welcome. Our journal was launched on March 21st, 2017, and we have totally published 324 articles and got, again, a lot of views and downloads. And here is our aims and scopes. The journal welcomes all submissions that possess significance and scientific excellence within the following topics related to endoscopy and other minimally invasive procedures, including general surgery, urology, bariatric surgery, and HPB surgery, of course, and the other surgeries. And here are some databases that we have been accepted. For example, the Scopus, Google Scholar, ResearchGate, and some memberships of our journal. And we also communicate with some media partners, for example, some international meetings. So if any of you intend to attend some international meetings or webinars, welcome to recommend to us. And here are some of our editorial board members. And Dr. Han is also one of our editorial board members. He really gave us a great support. Thanks, Dr. Han. And here is the country distribution of our editorial board, including the editorial board members and the youth editorial board members. The majority of them come from the Italian, USA, and Japan. And here is our readership and authorship. So you can say in our readership, 80% are from the United States, China, and Italy. And in our authorship, 25% are from Italy, United States, France, Germany, and Japan. And here is innovation of our journal. This is the homepage of many invasive surgery. You can see a lot of information, for example, the keywords and some news and the link to submit and our social media platforms, of course. In the bottom of our homepage, here is the aims and the scopes and some dynamic data. All the data are updated in real time. And this is the article page. You can see all the data related to your article, including all the views, downloads, authors talk, actually scan of graphic abstracts. Here are some examples. And we also plan a lot of interviews and webinars with our scholars. Here are some interviews we have completed. And here are some webinars. We have developed our own webinar page to showcase a series of meetings organized by our journal to enhance interaction and exchange among scholars. So if you have any interest in these clubs, welcome to join us. And we also assign some awards, for example, the Best Paper Awards. And we will collect from our published articles, including the original articles and review articles, and give some prize, of course. So welcome all your submission. And here are some of our contact information. If you have more questions, welcome to contact us at any time. So that's all I wish to introduce to you. Thank you, Dr. Han.
Yeah, thank you, Lilian. Thank you very much for your kind introduction of the mini-invasive surgery. So I am so glad that the mini-invasive surgery is becoming more powerful, and we all appreciate the mini-invasive surgery support for our webinar. This is the discussion time, but we are already 25 minutes behind the schedule. I'm sorry, because there are so many participants, but I think Dr. Farai and Dr. Rafael and my friend Gianluca and Ella Aslam. But we are sorry that we are behind discussion. We don't have any good time for the discussion. Actually, it is a little tight schedule because some speaker may need more than 10 minutes, but it's a very clear message that we have no further question on this. So, but I'd like to ask each speaker say hello to everybody and some comments on their issue. So first, I will ask Dr. Roberto Troisi to say hello, greeting to everybody, and say some important issue of your speech. Professor Troisi.
Thank you, Professor Han. I appreciate this webinar. I greet everybody, and I think we saw nice things, and there is for sure an evolution which is unstoppable in minimal invasive hepatopancreatic biliary surgery. And I'm sure that the technology will help us very soon in improving the quality of our operation. Thank you so much for my invitation.
Thank you, Professor Troisi. And Dr. Joe?
Yes, thank you, Professor Han, and thank you, attendees. This is my great pleasure and honor. I think still HPB surgery is very difficult, so we must know open surgery and laparoscopic surgery and robotic surgery all together. So that means that we have some more options. So we must learn together and we must go together, I think. Thank you very much, and I hope to see you soon again.
Thank you, Dr. Joe. And we move to Dr. Fabrizio Penaro. Are you with us? I think Dr. Penaro is just other walking. So I move to Dr. Aslam Ejaz.
Yes, thank you again, Professor Han. I really appreciate it. These were wonderful presentations. Clearly, everyone is pushing the boundaries of what we can do minimally invasively, and I think the next phase is to focus on how we can learn from each other, but also teach our next generation of residents and fellows. So thank you very much again.
Thank you, Dr. Aslam Ejaz. Thank you very much. And we move to my friend, Dr. John Martini. Dr. John Martini, would you turn on your mic?
Sorry. Thanks again for putting this together, and thank you, Lillian, for support from the journal. And I would reiterate, we're pushing robotics as much as we can. It's starting to hit an incline in the United States, so we're seeing probably 3 times as many doing robotics as laparoscopy, and I think that's going to continue.
Thank you, Dr. John Martini. Thank you very much. And Dr. Kaufman, would you say something to us? Turn on your mic.
Okay. Yeah. Yes, surely minimal invasive HPB surgery is very demanding. And probably robotic surgery will be a way to improve in this setting. And also for a better diffusion, a faster maybe and easier diffusion of HPB surgery, especially pancreatic duodenectomy with respect to laparoscopic surgery, surely.
Thank you very much, Dr. Kaufman. I'm so glad to meet good friends in this webinar. So because of COVID, we didn't meet each other for many years, for 3 years, but I'm so glad to meet good friends. I hope that we can meet each other in person in near future. And I appreciate all the speakers for excellent lecture. And also I appreciate Mini-Mystery Journal for supporting us. I hope that you can meet again. Thank you very much. Thank you.
Thank you so much. 감사합니다.
Thank you, guys. Have a good day.
Thank you for all your support.
Thank you. Bye.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.
Bye-bye.
Bye.
Bye, Ocean and others.
Bye,
Thank you.
Roberto. I think Gianluca is around here.
yeah. Gianluca is
And Ella is around here. Yeah. Thank
Ella
you.
is also.
Yes, bye.
Oh,
Have a
Bye.
good rest and so on. Thank you, Lilian. Thank you so much.
Gianluca.
Thank you.
So
Lilian.
Ella
Bye.
will come in Korea, right? Ella will come.
Roberto
Korea.
will come in maybe HPB Busan, maybe. I don't know.
Yeah. In March.
Yeah.
It will be March.
Yeah,
Next
March, Busan.
Yes.
Yeah, March.
Thank you.
So see you later. But Roberto, because Saudi Arabia, they say they have some problems to getting visa for me. That's why they asked me to have online. How about you? You attend in person in Saudi Arabia?
No, I had no problem because I applied online and I got immediately in 10 minutes time. It's very strange.
Yeah, but
I know.
they've said the Dan Duda is the Secretary General of the ISO. He asked about the problem that they say there are several countries has visa problem. That's why, yeah, I have to attend by online.
Okay.
Thank you very much, Roberto.
Okay.
Dr. Joe.
Bye-bye.
Bye-bye.
감사합니다.
감사합니다. Thank you.
State now to the kidney, but of course it's still the robotic. And so yes, let us know what you can present to us, Giovanni.
So thank you so much, Professor Osweiler, and thank you so much for the MS webinar for having me here today. So today is a very sunny day here in Leh, 6 a.m. So I'm very, very happy to be here with you and with all the esteemed colleagues. So I will talk to you about the robotic partial nephrectomies and the impact of surgical host and disease factors that may have any kind of impact on the perioperative outcomes and on survivals. So I have nothing to disclose. So as you can see here from this chart that is coming from the surveillance epidemiology and the results of the SEER program, the kidney cancer represents the 10th most common malignancy in both males and females. And in the United States in 2022 are expected around 63,000 1,000 new cases and more than 84,000 cases in Europe. And as you can see here, the trends are going up over time due to the new imaging techniques that can find some incidentalomas. And as you can see here from the slides, that is showing that the 74.1% of the patients with kidney cancer survive at 5 years. And, you know, when we have this kind of cancer, one of the things that we have to consider is that radical nephrectomies and partial nephrectomy represent the gold standard for the treating of this type of cancer. And though the randomized trials that has been published are showing that equivalent tumor control and superior functional outcomes, when you're looking at the RCT or CT 30904, confirmed the oncological findings, but failed in demonstrating any strong advantage in terms of renal functional recovery for partial nephrectomy. Those are the results for the randomized clinical trials. In the real world data, we know that this is totally different. So one of the things that we have to consider is that the partial nephrectomy is the recommended treatment for small renal masses, T1 tumors, so less than 7 centimeters, in solitary kidney, bilateral renal masses, and when you have a compromised preoperative renal function. And looking at these, we know that in the past 20 years, we witnessed with the important shift and swing from the open surgery to the laparoscopic surgery to the robotic surgery. And, you know, Professor Osweiler is one of the superstars, our rock star in our field that bring really the new minimally invasive surgery and techniques into this field. So, and here you can see how the trends over time change, especially in the US. So here you can see the data from the Premier Care database, a huge outpatient database that is collecting millions of patient encounter. And right now, as you can see here, the robotic partial nephrectomy or the robotic approach is the preferred approach that passed from 0.6% around 2006 to around the 66% right now in the US. The other 34% are done laparoscopically. So I would say that right now, open partial nephrectomy is something that is not even an option, especially in the developing countries. So, and the other thing that we have to consider is that how also our patients are looking for information on Google. So here you can see one of our recent publication that was looking at the trends over time of searches on Google. And as you can see here, for robotic surgery, well, there is a huge increasing trend over time with 33% more of searches on Google from patients all over the world looking for more information regarding the robotic approach. So 2004, why is important? Because in 2004 has been published the first report on robot-assisted laparoscopic partial nephrectomies, and from 2004, and they were concluding that the Da Vinci's assisted partial nephrectomy is feasible and can be safely performed using a transperitoneal or a retroperitoneal approach. So again, one of the things that we have to consider is that what happened after 2004. So when we are looking at the publication that has been published from 2004, 2018, etc., as you can see, there is a huge trend over time of new evidences regarding the robotic partial nephrectomies. So for this reason, we decided that, and of course, on the robotic partial nephrectomy, so on the outcomes after robotic partial nephrectomy and talking about survival outcomes, perioperative outcomes, etc., there are three key factors that has been taken into consideration: surgical approach, the tumor characteristics, and the patient characteristics. All these three characteristics of patient, tumor, and approach may have an impact on the outcome of interest. And so one is naturally wondering how robotic partial nephrectomy in 2022 compares with the other surgical approaches, how robotic partial nephrectomy techniques compare each other, and how tumors and patient characteristics impact on the perioperative outcomes of patients undergoing robotic partial nephrectomies. So we try to answer to these three key questions, performing a comprehensive systematic review and cumulative meta-analysis, looking at perioperative outcomes, functional outcomes, and oncological outcomes.
evaluating all the possible aspects that may influence the outcomes after partial nephrectomy. And we summarize all those findings in a 4 paper that has been recently published in a European Urology Focus and Journal of Urology. So if you want to read more about the summary that I will show right now, everything is reported in those 4 publications. So we performed, of course, a systematic review looking at the according to the PRISMA. Everything was rated according to the Oxford level criteria. We followed the AHRQ guidelines, and we register, of course, our protocol on Prospero. We search on PubMed, Scopus, and Web of Science. And I will make it for sake of brevity. Here you can see the total number of papers that we reviewed. So we reviewed around 12,000 papers. 270 papers were included in this systematic review and meta-analysis. Looking at almost 45,000 patients underwent any kind of partial nephrectomy approach with several surgical approach and techniques and 10 patients and tumor characteristics. And we try to condense everything in 856 forest plots that you can find in the supplementary material of our systematic review. But of course, as you know, for sake of brevity, it's always difficult to show 56 forest plots. So we decided to create a new composite criteria. The name is summary forest plot. And then now I'll show you just how it works. And then we can move to the results of the comprehensive review that we made. So typically, a systematic review and meta-analysis evaluate a mean of 16 papers, generating a mean of 6 forest plots. And as you can see here, our systematic review evaluated 270 papers, generating 866 forest plots. So to try to summarize everything, as you can see here, this is just an example of all the outcomes of interest that you can find in the panel A, and we summarize them in the panel B. And we call these summary forest plot, where you can see here in each line represent one of the forest plot. And if you want to find more information regarding that particular comparison, you can find all those informations in the supplementary material. So let's go and try to make it simple. And as I used to say to our students, our residents, just follow the diamonds. So let's talk about the impact of surgical factors on robotic partial nephrectomy outcomes. So we talk about the comparison of open versus robotic, laparoscopic versus robotic, transperitoneal versus retroperitoneal, and the different type of ILR technique control, such as off-clamp versus on-clamp, selective and super selective versus on-clamp, early on-clamp versus on-clamp. Let's focus on the open versus robotic. So as you can see, a number of studies that were reported were a total of 33 papers with taking into consideration data from almost 9,000 patients. On the right side of the screen, you can see the forest plot, the summary forest plot. Each line represents one of the outcome of interest. So when we are comparing open versus robotic, the open approach was superior compared to the robotic approach in terms of operative time and work ischemia time. The superiority of the robotic approach versus the open was in terms of estimated blood loss, transfusion, postoperative complications, length of hospital stay, readmissions, and 90 days. The eGFR decrease, the overall mortality and the recurrence, but no equally outcomes in terms of conversion to radical nephrectomy, intraoperative complication, even though there is no formal, so far at least, no formal definition for the intraoperative complications, which will be answered by the ICARUS Global Surgical Collaboration shortly. No differences in terms of post-surgical margins and no differences in terms of cancer-specific mortality. So so one of the questions that we can have is, okay, we know that there is a selection bias. In the majority of the cases, bigger tumor and tumors that has an higher RENA score, of course, undergo an open surgery versus the robotic approach. So we try to perform some sensitivity analysis according to the RENA score. So selecting only those publications for which the RENA score was similar between the two cohorts. So looking at the open versus robotic partial nephrectomy comparison and looking at only the studies that has a mean RENA score that was adjusted, Well, the story is pretty different. Open partial nephrectomy has nothing. We were very surprised. No superiority of open partial nephrectomy versus robotic partial nephrectomy, but as you can see here, the equality of the outcomes of interest is even higher when you're comparing robotic versus open. And therefore, again, as you can see here, approach matter, but one of the things that we have to consider is that also the disease characteristics. Some of the questions, fortunately, will be answered with the new trial, open versus robotic, that is undergoing. One of the member of our YAO team, Karl Kowaleski, and the team that is working with, they are now undertaking this huge randomized clinical trial comparing open versus robotic partial nephrectomies, and I'm pretty sure that some answers will come from them. And what about the complex renal masses? So when you have a renal score more than 7, so when you have something that is really, really big. So as you can see here, again, the quality of robotic partial nephrectomy open was in terms of operating time, transfusion, intraoperative complication, major complication, and positive margins. Of course, those results has to be taken into consideration with caution, because again, everything that I'm showing here is biased by the retrospective nature of the papers that has been included in the meta-analysis. And again, those are the data that should, again, everything should be taken with caution. Let's compare laparoscopic versus robotic. And as you know, there are 51 publications comparing open laparoscopic versus robotic. The total number of patients was around 8,000. And when you're comparing laparoscopic versus robotic, considering the prospective and retrospective studies that has been included in this systematic review, the robotic partial nephrectomy was superior to the laparoscopic partial nephrectomy in terms of warm ischemia time, conversion to open, conversion to radical nephrectomy for intraoperative complication reasons, transfusions, intraoperative complications, positive margins of overall mortality. And equality between the two approaches was found in terms of operative time, estimated blood loss, post-operative complication, admission, and case-specific mortality. Again, those data should be taken into consideration with caution, because again, the majority of those trials are retrospective. Again, let's compare laparoscopy versus open using the same RENA score. And as you can see here, again, superiority of robotic partial nephrectomy was found in operative time, warm ischemia time, conversion to radical nephrectomy, and length of hospital stay, but no differences for RENA score more than 7 performed laparoscopic versus robotic in terms of the estimated loss, transfusion, post-operative complication, and post-surgical margins at recurrence. Transperitoneal versus retroperitoneal. Again, all of them were done robotically, but here we are comparing transperitoneal versus retroperitoneal. 5 studies were comparing for almost 1,000 patients reported. And as you can see here, we found an equality in terms of transfusions, conversion, intraoperative complication, postoperative complication, meaning that the robotic approach can be safely done transperitoneally and retroperitoneally. Hilar control, different techniques. We know that there is an off-clamp versus on-clamp. 9 studies comparing, so I will go for sake of brevity. But no differences in terms of transfusion, conversion, and post-surgical margins, which means that is extremely important. One of the things that we found is that when the robotic partial nephrectomy was performed with an off-clamp approach, OR time and the decrease of percent of the GFR was superior in the off-clamp versus the on-clamp. Again, we talk about surgical approach. Let's talk about the tumor factors. So if the question can be, can the robotic approach be performed for complex renal masses? How they compare when you're comparing more than 4 centimeters versus less than 4 centimeters, endoscopic versus esophageal, hilar versus non-hilar renal masses, and anterior versus posterior tumors. Here you can see the comparison between the different renal scores. So according to renal scores, again, remember that the definition of complex renal masses can be defined according to the renal or to the Padua. 10 studies compare comparing almost 1,500 patients. And as you can see here, there is a comparison between the robotic approach that can be performed for complex renal masses versus non-complex renal masses. When you're comparing the robotic approach performed for more than 4 centimeters versus less than 4 centimeters, as you can see, there is a superiority, of course, of the outcomes of interest when the robotic partial nephrectomy is performed for renal masses less than 4 centimeters, but no differences in terms of intraoperative complication, positive surgical margins, and overall mortality rate, meaning that the robotic approach can be safely done. Also, might be, let's put it this way, might be safely done also for renal masses more than 4 centimeters. The terms might is related to the fact that the majority of the studies are retrospective. So again, those data should be taken into caution because because of the nature of the studies included in this meta-analysis. And let's talk about patient factors. So can the robotic partial nephrectomy be done for a patient with less than 70 versus more than 70 years old? Can be done with abnormal BMI, with the CKD, or with prior abdominal surgery. So let's check. 2 papers compare less than 70, more than 70. So definitely we need more data on this. We saw that when the robotic partial nephrectomy was done in a patient older than 70 years old, we found basically no superiority and no inferiority of the in 70 versus less than 70, but equality in terms of operative time, estimatable loss, warm ischemia time conversion, transfusion, etc., which means that in selected patients, we might recommend also performing the partial nephrectomy, the robotic approach, also for patients older than 70. Again, here we're talking about just only 2 papers, and definitely if there is anybody in the audience that want to run any prospective trial, it should be done definitely, because this is an area that needs and requires definitely more data to answer the questions. Abnormal BMI, 7 studies, almost 3,000 patients. And as you can see here, there is a superiority, of course, of normal BMI versus normal BMI in terms of operative time, estimatable loss, and overall postoperative complications, but equality of conversion, transfusion, specific minor and major postoperative complication, intraoperative complication, positive surgical margins, and overall mortality rate. Again, this forest plot can show that the robotic approach might be safely done also for higher BMIs. Of course, in experienced sense and in selected patients. Again, we saw today that the host factors, such as tumor factors and patient factors and surgical factors, have an impact on robotic partial nephrectomy. And considering the available data from the entire contemporary English literature, robotic partial nephrectomy provide mostly superior at the minimum equivalent outcomes compared to the open across all the aspects. And some evidences, but not all, of course, for superiority of robotic partial nephrectomy over the laparoscopic partial nephrectomy is equally compelling. Off-clamp, selective, and super selective clamp and early on-clamp hilar control techniques are safe and feasible and can be done as an approach during the robotic partial nephrectomy with similar perioperative and oncological outcomes compared to the on-clamp robotic partial nephrectomy. And of course, minimizing the global renal ischemia may provide superior renal functional preservation. However, more data are needed and are necessary for a definitive conclusion in this regard, and we know that. Host factor impact on robotic partial nephrectomy, tumor size and complexity, as well as the baseline of the patient comorbidity correlated with perioperative outcomes after robotic partial nephrectomy. And patients with comorbidity, such as, for example, advanced age, abnormal BMI, CKD, or prior abdominal surgery, should always be selected very carefully. So again, one of the biggest limitation of the entire thing that I just showed that we need to acknowledge is that it is almost impossible to evaluate the real impact of the surgeon expertise on the reported data. And this study did not consider the amount of parenchyma spared between the comparison group. which means that we know that the more you spare, the higher is the chance that your decrease of the GFR will be lower. And the overall suboptimal level of evidence, so there are no randomized clinical trial right now, and many are prospective or retrospective study with the heterogeneous group and the selection bias at the very beginning. And even though we try to do multiple sensitivity analyses to try to adjust for confound these variables, yet it is impossible to adjust for everything. And therefore, again, those results should be taken with caution. So again, robotic partial nephrectomy has now emerged as a safe, effective, and sometimes even prefer the partial nephrectomy approach for the treatment of small renal masses. And given the adequate robotic expertise and a careful patient selection, robotic partial nephrectomy can deliver excellent outcomes, even for anatomically challenging tumors or abnormal patient characteristics. So again, if you want to find some more information about the studies that we included and the limitation of these systematic reviews, please feel free to check this publication, which now are in open access, so everybody can download them. And thank you again for this kind invitation.
So thank you very much, Dr. Giamatti. I had the honor to listen to the early version by Inderbeer at the GU surgeons meeting for the first time. And at that time, I think that there was one question for me is, of course, how, as you know, this easy thing, shit in, shit out. So problem that you say, okay, if you do a vast analysis, how are you sure about the quality of the data that you put in your study? Can you maybe comment a little bit on this?
Yeah, definitely. So again, one of the there is always a saying, say garbage in, garbage out, right? So
exactly.
You know, and sometimes when you are performing a meta-analysis, you can amplify the limitation of the study that you are including in the meta-analysis. One of the things that we can do in order to minimize or at least to try to understand if there are some selection bias in the comparison groups is first run a biggest meta-analysis with all the data. The second thing is just selecting the propensity score or match comparison studies and to compare the findings with the main meta-analysis. And when it's possible, to do it's called backwards meta-analysis. So when basically you are meta-analyzing the baseline characteristics, and then you're going to select only the study that has a given patient characteristics that is not statistically significant different, and then you're going to plug them all in a different meta-analysis or sub-analysis. So we try to do that again. That's why we have 856 forest plots. And again, what we saw is that when adjusting by those confounders, of course, the enthusiasm regarding the robotic approach versus the laparoscopic approach was lower, which means that those laparoscopic and robotic approach are more similar than what we found. We saw, of course, some, still some differences when you're comparing open versus robotic. But again, I really believe that the majority of the answers that we have to our questions will come up with this new randomized trial that is comparing robotic versus open that is run right now in Germany. And I'm pretty sure that in 1 year from now, we should have some data on that.
I think that this is what I see the purpose. It's a lot of effort, just maybe to get out, as you pointed out, some of the open questions. For me, for example, and you know a little bit within the Birgil, there is not a clear correlation, even in your studies you have, between warm ischemia time and the loss of GFR. So sometimes they are equal, but the robotic group is better or something, even if the warm ischemia times are equal. So this is not completely.
Professor Rosweiler, you cut out a little bit. What you're saying?
Do you hear me? I know I had some comment here. Do you understand me now?
Yes, now I can hear you. Yeah.
So you know about the hypotension approach that Birgil used. This might not be very good for renal function. It might be good to not for less ischemia, but of course it might interfere with the renal function. So I think there are some things that are not 100% clear, and it's not your fault because you are just trying to use a technology or let's say a systematic analysis to get out some of this data.
Yeah, correct. So, but again, there is also the data from the clock study that are showing that there are, not so many differences. And again, there are some, I would say that the fact that we wanted to go out from this retrospective world, in order to, and you can see that, so there is a huge enthusiasm in trying to perform some new randomized clinical trials. And that, of course, is everybody all over the world that is trying to do that randomized clinical trial should be, complemented for sure, because that is the real way that we can have for, going out from these impasse of the retrospective studies. This is what we have right now. So again, it can give us just a picture of the situation, and systematic reviews are just not only a way for summarizing the data, are also a way for showing the limitations and try to move out from those limitations to improve in the patient care.
Exactly. Thank you very much. So to the sake of time, I think we have to continue. So I think Gerd is here, Gerd Deneyer. So now it's really a very interesting topic because we are talking about a new device. This is the Hugo RAS system. And we are really looking forward to see what is going on, what you can show us. I had the opportunity to see something about it, of course, and I know that you in Alstom are one of the departments that have the really first experience with this. Gerd, please, could you start?
Now you can hear me for sure?
Yes, now we hear you, yes.
Okay, so on behalf of my colleagues and myself, of course, I would like to thank you for the kind invitation to present our first experience and results of the introduction of the Hugo robotic system that was for many years expected to come into urology in February this year. And I think we were happy to have it here after it was promised in the end of 2021, but I think then they had some technical issues that were not perfectly, and so actually in the beginning of in February 2022, my colleague Alex Matri had the honor and the pleasure to do the first case, the first in men case of a robotic prostatectomy in Europe. Medtronic had already delivered its system in I think South America and also in India. Some of us know this, and they had done some cases there. But actually, I think their standard program, they wanted to test it mostly here in Europe. So here you can see an overview of the system where you see there is an open console. There are 4 robotic arms, and of course the control unit. And we will run through this different parts of the systems quickly, and then I can share you some introduction with the first cases of robotic prostatectomy that we did, and also with the continuation of the program. So let me scroll to the next slide. Okay, so here you have an overview of the console with the different pedals. So let's first focus a little bit of the console, so which is completely different, of course. Is one point that is the open console. We are all used to the immersive console of the intuitive systems, XI or SI or the X systems. Is there an advantage on it? Yes or no? I think it gives a better overview, a better connection with your operative team. And due to you need some special glasses that you have to wear. You can wear them without problem above your own glasses. As you see, I wear glasses, so there's no problem. And you see here some eye trackers at the head of the screen that follow these glasses, and that will be checking that you are just focusing on the patient on the screen, let's say, and otherwise you will not be able to move the instrument. So a little bit the safety system that is like in the immersive consoles. We have a small iPad that is controlling your different settings. You can of course adapt the settings of the console, of the height of the screen, the depth of the pedals, the height of the beam here, and to your own personal preferences. So the visualization is, of course, a 3D visualization, as we know, that is, of course, necessary in modern robotics, and no doubt. The touch screen is, as I said, able to control the settings. We don't have the Tile Pro connection yet, but this will probably be integrated soon. It is an ergonomic system, no doubt. And what is also different and important to know is that you have here the different manner of instrument control. We are used to pinching instruments like a pinset grip, and this is like a pistol grip in controlling the instruments. So actually, this is what asks some adaptation. We are sometimes running two rooms, and meaning that if one room you're doing, you've done like an partial nephrectomy, you have to switch to the room of the Hugo, and then you have to get used to the different from the pinch grip that you go back to the pinset to the pistol grip in the Hugo. So this asks a little bit of adaptation of your mind, but actually we had no big problems with that. I also want to give you some feedback of the training. So they also have a training simulator that is available, and that of course has the same or similar, I think, simulation exercises to get used to the system. I think if you are using any new technique, whether it is a robotic system or a new laser, you always need a good technical training. So then, of course, we have the control tower here, which is used with instruments of Storz. I think it was good said that they didn't have developed their own instruments. I saw recently the Hinotori system, which is a new robotic system. They also use Storz imaging, so you have a good quality light source. You have good quality 3D camera. You have, of course, the own energy platform there. That is, I think, Covidien and Medtronic. They were very well in that. Okay, you have an interactive display here that you can that you have to use just to confirm the settings of the arms and whatever. And which is an important point as well. And I think this is really an advantage. We will come back to that later. Is this digital surgery, touch surgery enterprise? Is a kind of recording, storage, and analytic platform that was simultaneously introduced with the robotic system, and that is really, I think, in training and in self-evaluation and quality control, an important point. So let's go back then to of course, the master-slave system, the arms. You see here that the system is basically developed with 4 different cards, with 4 different arms that are each of them differently controllable, which have different pedals and whatever. And you see they have a different height. They have the same. They have an how should I say an height setting that ranges from 20 to 100 here, just where you can higher and lower the arms. And they have of course 8 degrees of freedom that are here available in this different joints here in each of the arms. So here you see a setup. Let's go further. So, and this is what I think is an advantage of the Hugo robotic system, that it will be easier of use in multi-credit surgery. We all know, of course, the XI was a huge advantage compared to the SI system. That was really a progress that Intuitive made, and they have done, of course, a good job. But here, with the different cards that you can like say do your own modulation towards the patient, you have the possibility to adapt the arms to your own preference and to the position you want to get them on some point. And so each arm, as I said, has 8 degrees of freedom, can be used in multi-credit surgery. And you see that here you have different joints and different controls. You have different buttons as well that have each their own name. We will not go too much into detail, but all these settings, they make that the card and the system is very modular and very tailorable to the kind of procedure you want to do. So this means, of course, that, as I said, there is for all procedures, they have standardized settings and standardized guides, of course, to help you in how to dock the arm, because this is something that that surgeons think, okay, the docking will be difficult. Actually, you have to get used to it, and nowadays the docking takes just like a few minutes, so this is not really an issue. But you have to know, of course, on which angle or on which degree every arm should be positioned in the positioning of your patient, which is the degree that you need for that arm, or from which degree he should come. This is one point. And the other point that is important is also, you can see it here on the side of the screen, each arm has a variability of minus to plus 30 degrees of tilting. And so you know for each arm I think it's coming here. Yeah, like this is like just this is our patient, and you see that the forearms are here docked towards this patient for the kind of procedure, and you know, okay, so my endoscope is a tilting of 0. It has a docking of 300 degrees, and it's this one. We always start counting on the left side of the patient, go clockwise. So meaning if you, this is what we start. So this is a 90 degrees docking of the card with a 15-degree tilting. You see here the docking is 140 degrees with minus 30 the tilting. You have a 20, and here you have a 300 degrees. So there is a sort of kind of setup guide for the different procedures that you have to do, how you have to tow the arms, and how you have to, which kind of tilting you have to use. Considering the instruments, they have a lot of instruments available. The standard instruments, I think, that we are used to, like the Maryland bipolar, the grasping bipolar, clip appliers, needle drivers, Ligasure is available, and so on. And so these are the same instruments, I think, that we are used to use in robotic procedures, in different procedures, and they had some issues with the bipolar, but that will be solved soon. And so we made it possible to do like the first case, as I said, in February this year. And so, of course, you can see here the trocar configuration. For those that have experience in robotic surgery or robotic prostatectomy, it's a little bit like an SI configuration, meaning that you have here the camera port, that should be like about 60 centimeters above the pubic bone. And then you have to take in mind that both arms, the right and left arm, have to be a little bit lower towards the camera port. The fourth arm, this is tailor-built on the same level of the left arm or the right arm, or it can also be a bit higher. So you see, we use the standard configuration for the sport position. We also used an air seal and a 5 millimeter degree. And of course, we were able to do the procedure quite smoothly because we have been doing all the surgeons of our team, of our group, have been doing the training on cadaveric training in Orsi Academy before we could go on our first live cases. These are the different colors. I don't think I have to go too much into detail. The different instruments I already mentioned, the different cables and instruments and energy possibilities that you can share there. And as I said, we did it almost more than 6 months ago, actually. Yeah. So there are some pictures. I will not go with you through the whole video. But you can see some pictures here, and I think you see that the instruments have the same degrees of freedom inside the body as we are used to have with the XI or with the intuitive system. And the procedure on itself, of course, is actually the same as you are used to do in an intuitive point. This was the publication of our first series. So coming back again, maybe what is different concerning intuitive. If we know that you are doing the XI, the robotic prostatectomy with XI, I think in my experience, and I think in most of us, we sometimes had collision of the fourth arm with your left hand or with your right hand, depending on how you do the trocar positioning. And this is actually something that you can in Hugo you can completely avoid. So I think in intuitive you have to realize that it's like a centripetal trocar configuration, meaning that your trocars are all centered and directed based on your laser line and your targeting towards the area of interest. And your fourth arm as well is also connected to that way. And I think in Hugo you can say, okay, my fourth arm can, like, the vector can come from another direction. You can tailor that arm exactly how you want to have it, and this will avoid your collisions with the fourth arm. And I think this was an advantage, at least in my opinion. So coming back to the first the publication of the first series that was published in the European Urology, I think in this summer. Yeah, here you see again a picture of the trocar positioning. Here you see an overview of the positioning of the cards towards the patient. So you see that in our prostatectomy cases now, we do it always the same. So we have the script nurse that is on the left side, assistant is on the right side. You see we have only one card on the right side. We have 3 cards here on the left side. It looks quite bulky, but actually there is enough place for the nurse to be there. We have standard tapes on the room of the OR, so we know exactly where it has to come. We know that the table is on the same position as always. We give the same degree of Trendelenburg, and so the booking takes us like not longer than 5 to 10 minutes when you have a team that is like quite experienced. So here are the results of the outcomes of the first 5 patients. I think they are quite similar to you would expect as an experienced team would do in their robotic prostatectomy series. So I think they went all well. We had no specific troubles. You have to know that it's a system that is quite very well developed with kind of alarms and safety issues. So if you are moving too roughly or too grotesque with your arms, you will have an alarm that you have to overcome. And those things are all things that you have to get used to and that you have to be trained with your team together. So we continued after starting up, of course, with the radical prostatectomy with all the other different cases. We haven't done cystectomies so far. We have done sacrocolpopexy, we have done robotic adenomectomies, urethral reimplantations. We have done, I think, one nephrectomy and also pyroplasty. We have been participating in the ELIS meeting last month with 4 cases that were streamed from OLV. And I think we've done about now, I think we've done about 160 or 170 radical prostatectomies. Some of them with lymphadenectomy. I think we've done about 15 sacrocolpopexies, more than 10 adenomectomies. So this is a bit the caseload that we have been doing here over the last 6 months, and that actually been the routine of treatment for this for the pelvic procedures in robotic urology robotics, let's say. Okay, so here you see some here you see the view as well. That was one of our fears in the beginning. In the sacrocolpopexy, you have to be able to have an access to the vagina with a valve, and you see here then is one arm is docked, or one cord is docked in between the legs of the patient. So also there, it's actually no problem to do the procedure as you're used to do. So coming back again for a few minutes towards the touch surgery system. So you see it here. There's actually a very well system. So it's available in a very smart, small recording unit that's like 15 on 15 centimeter. You need a small size iPad or iPhone just next to it to control it. And actually you can record the video as you are doing always, and you just push on recording, and then actually, I did like 2 cases on Monday morning and afternoon, and on Monday evening, you will always quickly get the mail into your mailbox that there is that the procedure has been recorded, and you have the application that you can open on the touch surgery platform. Okay, you can go there. You see an overview of all the cases that we have been doing, and you can easily click or select one case and then go in detail to it. You get like a mail quite soon after the procedure that it's available, and 1 day later you get an extra mail that your procedure has been analyzed, that has been processed through the analytics. And as you can see here, that's a combination of artificial intelligence and also with a human validation factor as well. You see, and it's quite correct. They have done a nice analytics on like the different steps of the procedure, going from bladder detachment over lymph node dissection and the pelvic fascia incision, bladder neck, and so on. And so if you are like in doubt, as I did last week, just went back to a case where I think we had a T4 on the apex with striated muscle in it. I just checked again the MRI, and I quickly went to the different steps, and I looked here to the DVC and urethral transection, actually to see if I could have seen it macroscopically. So you can go back. If you say, okay, I want to make a note, let's say like this was a nice case of nerve sparing, or I am in doubt, or I did a frozen section here or whatever, or the vesico anastomosis was like a little bit different from otherwise, you can make some notes, and this will all be easy to go back later on. It's actually a new form of let's say operative report that is I think ready for the future use. It's also upgraded with some new tips in this case that you see. If they take out, they have some let's say some data security and protection toolkit now. If you pull out the camera, you could like bring the patient's part of his body or his name that is labeled on some paper, or
Hello.
Hi, Dr. Geert. Your microphone is closed.
Yes, okay. So I think this is how we had a good training, and I think this is one essential part of course, doing good surgery, that you have a good technical training before you start using the system. So I think this was my last slide. So thank you. I hope you enjoyed this this lecture, and I have a few minutes time for some short questions because I have to continue my clinical work here. We have a little bit delay.
Okay, thank you very much. I think yes. Do you hear me?
Yes, I can hear you quite clear. Yes.
Okay,
Perfect.
so I've maybe two comments. Quick comments. What about the problems that they have? You know, from the live surgery that every 45 minutes you get a new scissors. Is this now solved, or is this a Barcelona problem?
Yeah. Yeah, actually, so that was the point, because they had some troubles with their instruments in the beginning, and that was a recommendation to have it changed after every 45 minutes. If you didn't do it, you could continue using it. So it was like more a safety measure than actually an obligation to do so. But now they have completely solved that problem, and actually that has completely gone. So now we don't change them anymore. So that is completely solved.
I see. Very good. And did you we're talking about bipolar? It's interesting that the Avatera system has only bipolar and has problems with monopolar, and you have problems with bipolar coagulation, or what was this? Could you give us some ideas?
Well, actually, I think personally that the Hugo system, which is using, of course, their own brands of electrosurgical surgical applications, they have a lot of experience in coagulation and whatever. So it's quite my perception is that the coagulation and whatever works very well. The problem they had with bipolar was that the instrument was not so strong at its connection to the endorest instruments, but that's solved as well now. They have made it stronger, and they have made like a stronger endorest configuration, and that is also solved now. So I think we will start using the first new instruments one of the coming weeks.
And the last question, you showed the ligature. So are you using the ligature already doing your cases?
No, not yet, because I think in prostatectomy it doesn't make so many sense to use ligature. But I think maybe in the future we will go on, of course, to also upper tract procedures, and I think ligature, like in nephrectomies, can be helpful.
That's what I mean.
Cystectomies, but we haven't done this. We haven't used it in cystectomy so far, but that will also probably change soon.
Okay, so we don't want to keep you up, and we are anyhow a little bit late in time. No, it was really great, and I think this is a fascinating technology, and we have seen it in Barcelona, and of course you also presented very, very nicely there. So I think we will hear in the future a lot of it. So thank you very much, Geert, and that you took the time to present to us. And now we come to my old friend, to my old friend Hubert Jonso, who will talk about one of his favorite things that he already early started with robotic adenomectomy. So we're not talking about radical prostatectomy, we're talking about adenomectomy. Hubert, please go on.
Dear Jens, the pleasure to be part of this session. And the snow in the background is actually not present in Switzerland yet, but we hope for snow and to go to ski soon. The previous presentation should be closed, so I couldn't. I'm able then to open. I cannot open the presentation. I cannot open my screen as the last screen. Gert should close his screen. Otherwise, I cannot open my screen.
This is interesting. Maria, as host, can you do this to close him and give the right to?
Okay.
To Hubert. I think that's what you have to do.
Yes. So robotic adenomectomy, thank you. Now we can go forward. There we are.
Yes, wonderful.
I think that's fine, huh? Okay.
Very good.
Okay. The pitfalls of long urethral surgeries are a long manipulation time, high local energies, bladder neck strictures, urethral strictures, incomplete resections, urgency frequency, prostate fossa infections, and urinary incontinence. So where is the place for robotic? And the history, open simple prostatectomy was introduced, as we know all, by Fryer in 1901, Millin 1949. The feasibility was first demonstrated for adenomectomy with a robotic system in 2007 at the AUA with a video contribution, and then followed the two first papers by René 2008 with 7 cases transperitoneal, and my group in 2009 with 13 cases extraperitoneal approach. Jens Stolzenberg, Uwe Stolzenberg confirmed this 5 years later. And so this is the story as we do it today. We do an extraperitoneal approach. We develop the technique more and more, and since some years we didn't change anymore. So we do an extraperitoneal approach. We go down as much as possible to the prostatic proximal urethra. In the middle, you see the exposed lobe here, and then we do the enucleation. We enucleate the gland. You can see then the urethral length musculature. We do a previous dorsal fixation and then end-to-end anastomosis in order to exclude the whole fossa of the urethra. This is the secret of the story. You exclude the prostatic fossa totally, and with that, I show you the technique now. This is from European Urology. Further emotion, an extraperitoneal approach. As you see here, for some groups, extraperitoneal techniques might be a little bit more difficult at trans, but why not? You can easily go with a forearm system in extraperitoneal approach, and anatomically it makes sense. You are not in the bowel. With the bowels, you don't need such a lot. The Trent-Ellenberger position as well. And up to 200, 250 milliliters, we have so far no problem to develop the adenomectomy. First, we do the apical preparation. Still, we do a ligation of the Santorini plexus in order to have less backflow during the enucleation. You see that here. Maybe it is not necessary. We could maybe increase the intra-abdominal pressure, but we work with 9 or 10 if possible. But you can go up as well. Maybe you can omit this suture, but it doesn't matter. We will see that no issue on potency and continence. You do then the bladder neck dissection. To a small bladder neck access is like in radical prostatectomy in this phase. Then you dissect the bladder neck, and you go down to the urethra. You push down the lobes. This is not a very long intraprostatic urethra, but go down as much as possible. If the ureters are very close, you can stent them until at the end of the operation. Usually I take them out if I have to stent, but if you have a good length away from the orifices, you don't need to stent. Then the enucleation, you are within the prostate fossa. Under vision, you can coagulate. Under vision, you can develop, and so you do the whole adenoma. You don't need to take out the totally adenoma, as you just need to have place to take back down the proximal urethral stump to the distal one, and so you arrive here to have done the adenomectomy, and this is now the dorsal fixation. We do not the anastomosis directly first, some, as you want to call it, rocker stick, dorsal fixation, whatever, and you take down here the bladder, dorsal bladder, as hemostyptic as well, but to relax the distal end-to-end anastomosis afterwards. And this is now then the next step. You do then an end-to-end anastomosis. Still, this is the hemostyptic sutures, continuous sutures, barbed suture, V-lock. And then after have fixed the bladder down already, you do retrovesical anastomosis. We do here 2-0 suture, barbed suture, double-armed, and you reach end-to-end anastomosis without tension, as you have pre-done the relaxation sutures behind. And so you have a situation like as in a radical prostatectomy. So we have an indwelling catheter. We take then the catheter out after 24 hours. We do an additional suprapubic drain. So the continuous, the reconstruction of the prostatic ureter. This is the secret. You avoid totally the prostatic fossa, and you have no complications again from any anatomic structure in this area, mechanically, thermic, and you end here with the sutures. Above here, you see the capsule. You are away from the bundles. You are for sure away of any continence mechanism morphology, as you are always in the prostatic fossa itself. And this explains why the continence is 100% and no impaired erectile function. So at the end, you place your suprapubic drain then, and you suture the prostate capsule down to the bladder anterior wall, as well hemostyptic. And so you reach already the end of the procedure. I think we can go forward for time reason. You will see then the suprapubic drain coming down. And once done, we do still a drain for 24 hours. And then you will have finished. You can push it between, or you can push it outside. You remove the indwelling catheter after 1 day. The drainage you remove as well. Patient goes home with the suprapubic catheter. So you need no blood transfusion for sure. You lose 200 to 300. You have no urgency frequency and problems of the fossa itself. This is the cystogram after 5 days. For sure, the anastomosis is high, much higher than in after radical prostatectomy. And these are the results. The first 17 cases with a follow-up more than 1 year. The continence is 100%, and the IF, the continence rate is full. The IP says they are not disturbed anymore. The potency is not impaired, and we have a high trifecta rate. In summary, the extraperitoneal robotic-assisted simple prostatectomy with an intraprostatic ureteral reconstruction is a minimal invasive technique, as we have seen, to treat large adenomas, a low complication rate, a good functional outcome in as well incontinence and potency, with no post-operative bladder irrigation, no post-operative bladder irrigation imaging, no post-operative bleeding and infections from the prostate bed, and for sure without any urethral trauma and potential urethral bladder neck stricture. Thank you very much. So I'm again with you.
Okay, thank you so much, Dr. Hubert. And thank you so much for your excellent presentation. And Professor, our chair, his internet has some problems, so we will have.
Okay.
So we will have.
I might. Okay.
Yeah.
So I might take over the discussion for sure. Are there questions from my colleagues?
Okay. So let's welcome next speaker. Dr. Ricardo.
Yes, good afternoon to everybody. I would like to thank Professor Asweiler and all of you very much for this kind invitation and minimally invasive surgery for the opportunity to share with you some insights on the in the field of robotic kidney transplantation from deceased donors. This is really a frontier surgery nowadays. And I have to thank also Professor Breda and team for pushing this forward during the last years and for allowing our team to get experienced in this very, very nice technique. So I have no potential conflicts of interest to report for this presentation. However, I have a few personal disclosure. And my first disclosure is that I truly believe that kidney transplant centers and patients will always benefit by the formal involvement of urologists in kidney transplantation teams. This concept was written a few years ago by Julien Branchereau, who is a urologist and transplant surgeon in Nantes, in France. And I strongly believe that further research is needed to shed light on the role of urologists in the field of kidney transplantation. We have, with our team and also the Young Academic Urologists Kidney Transplantation team, we developed a survey to actually understand the role of European urologists in the field of kidney transplantation. And we found out that a number of urological centers, especially in France and Spain, do involve urologists in kidney transplantation team. And these urologists are exposed to several highly rewarding activities in the field also of minimal invasive surgery, and almost 1 out of 3 urologists were involved in robotic kidney transplantation as well. So my vision at the end is really that urologists and transplant surgeons should work together toward a common goal, and this goal can be really achieved through the opportunities that are shared by international societies, in particular by the European Association of Urologists, with all the sections dedicated to kidney transplant, such as the European section of transplantation urologists, the ERUS Robotic Kidney Transplantation Working Group that is led by Professor Breda, and the Young Academic Urologists Kidney Transplantation Working Group led by Angelo Territo. On the other side of the river, the transplant surgeon societies such as the EKITA and the European Society of Organ Transplantation represent key societies with whom urologists should collaborate with. So we try to put these in reality, and we organized recently a meeting in Florence involving urologists from Italy, urologists from all over Europe, and transplant surgeons, especially those who are involved in the European Society of Organ Transplantation. And we really believe that this might be the first step toward more collaborations between two worlds of urologists and transplant surgeons. So as you may know, most kidney transplantations are even today from deceased donors. And these are the international figures on donation and transplantation that were recently published in 2021. And as you can see, this is a slide from the Italian Transplant National Authority showing that the vast majority of cases of kidney transplantations are even today performed in the setting of deceased donors. And this is also true in countries like Spain, which has the highest rate of kidney transplantations from deceased donors in the world. This is also true for the United States, where 72% of kidney transplantation in 2019 came from deceased donors. So despite the fact that living donor kidney transplantation is still the gold standard kidney transplantation method, however, there is a mismatch between donors and recipients, and therefore the vast majority of recipients benefit from kidney transplantation from deceased donors. And we know that the surgical technique in kidney transplantation did not evolve very much over time since the very first transplant successfully performed in the 1950s of the last century. And although major improvements in the outcomes for transplant patients will now likely come from the field of immunology, we know that surgery may play a role, and this role might be played by robotics in this field. So thanks to Professor Breda and team in Barcelona, the ERUS robot-assisted kidney transplantation working group was created. And in 2018, the group showed the feasibility and safety of robotic kidney transplantation from living donors. In this slide, you can see some snapshots and some little videos of the technique that was conceptualized by the Vaticuti Medanta collaboration between the US and the Vaticuti Institute in India, and that was later on modified by Breda and team. This was also another paper in the setting of living donation showing the feasibility of robot-assisted kidney transplantation using grafts from living donors with multiple vessels. As you can see in this slide, in this case, we have a kidney from a living donor with 2 arteries, and we have shown in this paper that robotic kidney transplantation is feasible after extracorporeal bench reconstruction of these arteries, allowing to perform one single anastomosis in the recipient. So this is the largest European study from living donors using grafts from multiple vessels. And also in the setting of living donors, we have shown with the team of Professor Breda in Barcelona that the learning curve for robotic kidney transplantation for surgeons who are experienced in both robotic urologic surgery and kidney transplantation can be not so long. We use the Shewhart control charts and cumulative summation graphs to generate analysis on the number of kidney transplantation needed to be proficient in robotic kidney transplantation. We defined a trifecta outcome based on 3 outcomes: no major intra- postoperative complications, no delayed graft function, and rewarming time less than the mean +2 standard deviation rewarming time that in our series was 48 minutes. And using these graphs, we showed that the learning curve for arterial anastomosis required up to 35 cases. Complications and delayed graft function rates significantly decreased after the first 20 cases, and trifecta was achieved in 3 out of 4 patients after 34 robot-assisted kidney transplantation in each center involved in this study. So at the end of the day, we concluded that a minimum of 35 cases might be necessary to reach reproducibility. But please keep in mind that these surgeons involved in this study were already experienced in both robotic surgery and kidney transplantation in an open fashion. We also tried to show the feasibility of using intraoperative fluorescence vascular imaging to assess the reperfusion of both the graft and the ureter. And thanks to my friend Giovanni Cacciamani, we have published this in the World Journal of Urology, highlighting the value of this infrared fluorescence imaging also in the field of kidney transplantation, which was a frontier surgery at that time. So in this video, I will just show a little bit of the main steps of the procedure as we do in our clinic in Florence. As you can see here, the venous anastomosis is performed with 2 running sutures using a Goratex 6.0 needle and thread. The arterial anastomosis is also performed in a running fashion. We use 2 threads instead of only 1, as for the venous anastomosis. And at the end of the anastomosis, we check the revascularization of the graft using indocyanine green. And this is important not only for the graft, but also for the ureter before performing the vesico-urethral anastomosis. As you can see in this video, this is a very nice technique for the surgeon to be sure about how the graft is revascularized after the kidney transplant. And at the end of kidney transplantation, we flip the kidney and we put the kidney in a previously prepared extraperitoneal pouch so that the kidney doesn't, there is no risk of torsion after surgery. We check again the vascularization once the kidney is in position. We do the ultrasound, especially in, we did it at the beginning. Now we rely more often on indocyanine green. And as you can see, indocyanine green is very, very useful to check the vascularization of the ureter before performing the ureterovesical anastomosis. So as you can see, the robotic surgery can really provide a level of detail and precision that allows the surgeon to perform kidney transplantation safely. However, the potential role of robotics is highlighted in the latest guidelines of the EAU on kidney transplantation by highlighting that single-center studies are addressing the role of robotics in the field of kidney transplantation using grafts from deceased donors. However, we have potential issues with this kind of kidney transplantation, especially for the logistical challenges. And robotic surgery is still only being performed nowadays at few pioneering centers that are adopting this technology consistently. So we have an unmet need. The unmet need is really to develop a structured robot-assisted kidney transplantation program from deceased donors who represent the vast majority of donors nowadays. And the aim of this is to expand the pool of recipients who may benefit from minimal invasive surgery and to define the value and limits of robotics in this field. I would like to highlight that the value of robotics should be considered according to the value-based healthcare revolution that prompts a shift in the focus from the volume of services toward the value for patients. So we need to understand the value for patients that is defined as the health outcomes achieved by robotics relative to the cost of achieving them. So there is a lot of research to be done in this field. And as you can see here, beyond the submerged iceberg, we have a lot of topics to cover, such as patient-reported outcomes after open versus minimal invasive surgery, the cost of care, the impact of centralization of care, the impact of surgeons' skills and experience on the outcomes of these kind of challenging procedures, and so on. So our experience in Florence started a few years ago in 2016 and was based on 4 cornerstones. We have experience in open kidney transplantation because we are one of the few exceptions in Italy where urologists have always performed kidney transplantation since the late 90s. We had the Vaticuti Medanta technique and the Erus Ract technique for kidney transplantation, so we could rely on a codified technique for robotic kidney transplantation. And thanks to Professor Breda and team who came to Florence for the first times, we have been proctored by them to safely introduce this technique into our own reality and our own practice. But we were very experienced in robotic procedures for urology. We performed more than 3,500 procedures in the last 10 years. And we had a dedicated team, a modular training with a dual console and inclusion of young urologists in this robotic kidney transplantation program. We published in the BJUI in 2019 the first experience from deceased donors. So this was the real preliminary experience using robotic kidney transplantation from deceased donors. And as you can see here, there is not only a technical issue, but also a logistical issue, because you have to imagine that we should be able to perform robotic surgeries at times that are not elective, like weekends or nights. And we need to have the robotic OR fully available. We need to have a team. We need to have no exclusion criteria from the recipient. And we need to keep cold ischemia time as short as possible. And of course, also the graft evaluation during bench surgery should be really, really careful to avoid potential troubles during surgery. So we kind of selected patients at the beginning, but here we have shown that it was feasible and safe for patients. In this publication that is quite recent in European Urology Open Science, we actually compared our experience with robotic kidney transplantation from deceased donors to our experience from with open kidney transplantation using the same donors. This was not a randomized trial, of course, but as you can see here, the decision flow chart that came to the decision to perform open or robotic surgery actually depended mainly on the availability of the robotic team, the availability of the operating room, and the availability of the graft, of a nice graft with no abnormalities to perform a safe robotic kidney transplant. So at the end of the day, the vast majority of the times in which we couldn't actually perform robotic kidney transplantation in the setting of deceased donor was due to unavailability of the robotic surgical team. So this highlights the most important aspect of my talk, that is really how to train future robotic surgeons to improve the number of robotic kidney transplantation that are being performed in the setting of donors after brain death, that are the vast majority of donors. From a technical point of view, you can see that our technique involves a four-arm configuration, like in radical prostatectomy. We use the gel point device or the Alexis port to introduce the kidney for transplantation through a fan steel incision. In case of deceased donors, as you can see in the upper part of the slide, we can decide whether to cut or to maintain the Carrel's aortic patch. This depends on the amount of atherosclerotic plaques that we can find at the level of the Carrel's patch. Of course, in the setting of deceased donors, this is often a problem, and we encounter often very bad vessels, and sometimes we just decide to cut away the Carrel's patch and perform the anastomosis as in the setting of living donor kidney transplantation. The graft is prepared during the bench table. We insert a double J stent before kidney transplantation, and we just put the kidney inside through the fan steel incision, and the kidney is already close to the vessels where kidney transplantation will be performed. From a technical point of view, you can see here in this snapshot that in this picture, we have used the Carrel's patch for kidney transplantation, while in this picture, we have cut that away because there were too many plaques at the level of the renal artery. In terms of characteristics of patients, so in our experience, even if we tried not to select patients too much, at the end of the day, the recipient from robotic kidney transplant were a bit more were healthier and had less pre-transplantation dialysis as compared to recipients for the open kidney transplantation. And this might explain at least our results. But in terms of intraoperative outcomes, we did not find any important difference between robotics and open. In terms of postoperative complications, we did not find any inferiority, I would say, of robotics in this setting. And regarding follow-up outcomes, we had a better results in the robotic kidney transplantation group, perhaps due to the fact that less recipients were undergoing dialysis in the preoperative period. But if you see the univariable and multivariable analysis for three important outcomes, the DGF, the delayed graft function, so the need for dialysis during the first postoperative week, the trifecta, and the subop, and I would say an optimal renal function at last follow-up, so an eGFR more than 45 millimeter per minute, we can see that donor and recipient-related factors, but not surgical approach, were independent predictors of these outcomes. So this this study clearly shows, even if it's a preliminary experience, the potential non-inferiority of robotic kidney transplantation from deceased donors as compared to the gold standard open kidney transplantation, of course, in carefully selected recipients. Our experience nowadays is this: almost more than 1 out of 5 kidney transplants are performed robotically. And how we can overcome the challenges of robotic kidney transplantation in this setting, I think one of the best tools will be to use novel cold ischemia devices, such as this that was developed at Puigvert Foundation in Barcelona by Professor Breda, Angelo Territo, and team. This may allow to increase the time for surgeons to perform safely the anastomosis without increasing the rewarming time inside the abdomen. So I think this is a very promising tool to reduce the stress for the surgeons while performing vascular anastomosis intracorporeally. Another important tool is augmented reality. We have shown in this paper, still led by Professor Breda and team, that we can use augmented reality to predict intraoperatively where to put the vascular clamps during robotic kidney transplantation in case the recipient has a lot of atherosclerotic plaques that may increase the need for open kidney transplantation and open conversion, or at least increase the risk of intraoperative adverse events. And another important tool to overcome the challenges of robotics is really the power of science, is the power of collaborations across members and centers across Europe and beyond. As you can see here, these are all the members of the ERUS robotic kidney transplantation team that is led by Alberto Breda. And I think the power of this consortium is really to put data together on robotic kidney transplantation, and by putting data and analyzing data, providing audits on robotic kidney transplantation, also in the setting of deceased donors, we may be able to find the limits of this surgery. We are using a REDCap web-based data set that is actually managed by my team in Florence, and we have already data from more than 300 robotic kidney transplantations across multiple centers in Europe. Last but not least, as I was saying before, surgeons training is much important in this field. As shown elegantly in other fields like in partial nephrectomy, surgeons account for up to 100% of variability in measurable perioperative outcomes. And we know that innate skill is not easily quantified. So we need really to train future robotic surgeons in robotic kidney transplantation if we want to increase the power of this technique and increase the number of recipients who may benefit from surgery. As you can see here, these are data from my university that shows in green the percentage of robotic kidney transplantation from deceased donors across the last 6 years. And as you can see, this is still not sufficient as compared to the percentage of robotics in living donors. And this depends mainly on the surgeon that is performing these surgeries. And for this reason, I would like just to let you know that at the Orsi Academy, there is a course on robotic kidney transplantation. I had the privilege to do this course with Dr. Karel de Casteker and Dr. Breda last year. And I'm very proud to be now a proctor of this course together with them and Angelo Territo during this course. And I believe these are really important opportunities to train using animal models before starting the experience with humans. And last but not least, the EAU ESU working group on kidney transplantation chaired by Oscar Rodriguez Faba will shed light on the curriculum that is needed to perform safely a robotic kidney transplantation. So is robotic kidney transplantation a dream or reality? So my take-home message is that the real challenge will be to assess the indications and limits in complex clinical scenarios, not only in the elective setting of living donor kidney transplantation, but to define the value of robotics. Further research is needed to integrate extended reality technologies prospectively compare the outcomes with open standard of care, so open kidney transplant, increase the number of centers and therefore surgeons performing this technique after proper training, of course, and assess the cost effectiveness of robotics using standardized metrics. And my final message is that harnessing the power of scientific collaborations between referral transplant centers will be key to improve the quality of evidence and ultimately, hopefully, patient outcomes. I would like to thank all my team and my director, Sergio Serni, who is the professor and chairman in Florence and director of the kidney transplantation program, all the kidney transplant surgeons and colleagues who are working with me in Florence, and all the team of urology residents who are helping me doing research in this fascinating field. And I thank you very much for your attention.
I must say, I think you already mentioned basically everything, so it's a very long task. I have only one question because we are, I think, short of time now. What about the role of the surgeons? You know that you have a lot of transplant surgeons, particularly in Germany. We have still the centers, you know, Stöckle is a part of it, or Paolo Fonara in Halle, but Paolo Fonara, for example, he will stop now. And so the future of transplantation in Halle, I'm not 100% sure how it is in the future. So what is the role? Can we also, let's say, we want to have it in urology, but can we also convince the surgeons to move to robotic transplantation?
Thank you very much, Professor, for this question that I believe is key in this setting. We have shown that a collaboration with the transplant surgeons is feasible, and I think is the way to go. We tried to make this Congress in Florence 2 weeks ago an opportunity to share experience with transplant surgeons. I have to say that urologists, I'm very proud of this, but urologists are innovators, and they had much more experience in robotic surgery in general as compared to our colleagues in transplant surgery. But I believe collaboration will be key, and courses like the ERUS course at Orsi Academy, I think, are the best opportunity to be together and share experience, because they are very, very skilled in open kidney transplantation, but we are very skilled in robotic surgery and also open kidney transplantation as well. So I believe the power of collaboration will have to move this field forward, because robotic surgery has a role in my opinion, as a clear role, even if it might not be for everyone.
No, I'm totally convinced, and I guess the pioneers who are working on this prove it, as you've shown very nicely. But I guess you see it's a more perspective view, global view, how we can get this message around the world, and we cannot do it probably without the surgeons.
I think at least for centers, and in Italy we are an exception, because actually only Florence and Bari have a urological team performing the whole kidney transplantation procedure. I think the key will be to start collaborating with transplant surgeons, so urologists who have experience in, for example, robotic nephrectomy may be involved in robotic living donation programs, and starting from that, perhaps joint teams of transplant surgeon and urologists who are experiencing robotic kidney transplant may start new collaborations, because otherwise, if these words don't speak to each other, I think it might be challenging to increase these numbers outside referral centers.
Mm-hmm. Very good. So I think, thank you very much. I think it was a very great presentation that you gave. And so I think we are coming now to the end, because we've had really a wonderful overview today about everything, really new devices, upper tract surgery, lower tract surgery, and now even the transplantation. So I must say, hopefully everyone in the world who really participate, I heard around 800 people have listened to us. So I think this is a really great thing, and thank you to the Minimal Invasive Journal who made this possible. So, and now I wish you, for us, it's the afternoon, so, and a nice evening. wherever you are in the world, I wish you a nice following day. Thank you very much.
Thank you so
Thank
much.
you very much.
Bye.
Bye-bye.